Hello everybody and welcome to the 8th Histio UK Forum, this 17th of November 2022. We were just going to do a little bit of housekeeping with you before we get started. The webinar you're about to view or participate in is for information purposes only. Patients and parents, the webinar is not a medical consultation. We will be hosting Q&A sessions as time allows. The webinar is being recorded and will appear on our Histiocytosis UK website. All participants will be muted. You can submit questions using the Q&A feature in your webinar panel. Before typing your question, please check to see if someone else has already asked the same or similar. If they have, click on the like button, that's the thumbs up. This will promote the question and show the speaker the most popular questions first. If you're unable to see the Q&A window, click the option on your toolbar to open the window on your screen. Type your question and submit. We are not going to use the chat today to submit questions, only the Q&A feature. The chat function will contain a link to the combined survey and certificate of attendance questionnaire. I'd like to take this opportunity now to welcome your first host, Professor Claire Booth. Thank you very much, Claire. Over to you.
Thank you very much, Lynn. Yeah, welcome to the pediatric HLH session of this forum. And actually, we've got a really nice broad subject today. So we're really lucky to have Anu Rao and James Clark, who are going to give us a presentation around the National Pediatric HLH MDT, which herself and I set up a couple of years ago now. And then, so that's kind of about the clinical care and patient impact. And then Dr. Austin Worth from Great Ormond Street will be talking about novel therapies for HLH that are also currently kind of in clinic. And then I'll be taking a step back, talking about repurposing of drugs and small molecules to treat XLP and Zayat deficiency. So that's something that's a little bit more preclinical and translational. So I think we're running a little ahead of schedule, but I think that's not a problem. So I would really like to hand over to Anu and James and really thank them for pulling together the data on the National Pediatric HLH MDT audit. I'll hand over to you, Anu, first.
Thank you, Claire. Welcome, everyone, to this really interesting histiocytosis day. James and I are going to run this together. I will probably start my presentation and then hand over to James to actually give you a brief look at the interim audit data we have on the pediatric HLH MDT. I'm going to share my slide, and Claire, you may have to just confirm that
yeah, I'll do that.
You can see the screen.
Yeah, that's perfect.
Perfect. And you can see the first slide? National Pediatric?
National Pediatric HLH MDT.
Lovely. Okay, great, lovely. So as you can see, the people listed on the slide are sort of the key movers and shakers of the National Pediatric HLH MDT, but by no means are we the only ones who have really made sure that this MDT runs and continues to run successfully. It's really a team effort by very engaged clinicians who are interested in this really rare disease, HLH, and fundamentally with the aim of improving the outcomes for children and families. So the way we will do this talk is I will start off with the first few slides. James will then come in to give you a brief interim data on the audit, and then finally I shall conclude with a few summary slides. So the outline for my talk is just giving you a little bit of background on, why did we think that we needed a national HLH MDT? How did we go about establishing it? What are the terms of reference? and really wider engagement across other bodies who may also be interested in looking at HLH, either from a diagnostic or a therapeutic perspective. James will talk through the interim audit data. And lastly, I think I'd like to end this with what impact this National HLH MDT will have or has the potential to impact on clinical care and future opportunities. So the background is that Great Ormond Street Hospital provides a quaternary service for children with rare diseases. We receive referrals from secondary and tertiary care healthcare services for children with suspected HLH or confirmed genetic HLH. The referrals that we got impacted multiple specialties. So primarily hematology, because a lot of the children who present with peripheral blood cytopenias, organomegaly, are incredibly sick. The closest differential for children presenting in this manner is leukemia or some sort of malignant infiltration. And often it's the hematologists who kind of get involved as the first call. Separate to that, and equally important, are all the other specialties, immunology, rheumatology, and infectious diseases, who receive a fair number of calls of children who are either presenting with immune deficiencies or inflammatory conditions. And what we found separate to these external referrals is we were receiving internal referrals from within Great Ormond Street, coming from metabolic, intensive care, neurology specialties, telling us, I think we may have a child with a hyperinflammatory phenotype, which, you know, initially didn't look like HLH, but all our investigations really are coming up with nothing, and we think we might actually be dealing with a child with HLH. And what that made us sit back and reflect when we looked at our MDT discussions was, if you actually look at the time interval between the onset of symptoms and signs of a child with HLH or suspected HLH, when the penny drops, could this child have an inflammatory condition? There's a significant time interval. It can be from the onset of symptoms to going to your GP, which is your primary care, to then being referred to secondary care, to then getting specialist care. So that journey can be significant. It's not only about time, it has a significant impact on outcomes, because we know early recognition leads to better outcomes. Children present incredibly unwell, and often, sadly, we lose some children before they actually, are referred to specialist care services, because fundamentally there might be a delayed recognition, or the child is just generally too unwell when they present. So the themes that we were kind of getting from our own internal audit was that there's a lot to do with pattern recognition. People have to feel that the little pieces of a jigsaw in this acutely unwell, hyperinflamed child, it's not an infection, it's not behaving like an infection, this is something more. That pattern recognition was really important. Joining up specialties was incredibly important, because each of the specialties were dealing with these children with a very narrow focus of what they knew that was specialist to their area, but there wasn't the cross-pollination across specialties to say, actually, this might be a neurological presentation of HLH, or actually, this might be an infectious EBV-driven infection, but fundamentally, there's probably an immune deficiency going on. And therefore, there was what we felt was delayed diagnosis, not due to any fault of one particular specialty or one particular family. It was just that this is an incredibly difficult condition to diagnose. There is no one single blood test you can do to confirm that someone has HLH. It's a battery of tests and pattern recognition. Also, there was a reporting bias, and at times there was under and overestimation of the actual numbers of children that we had with HLH. So we decided that actually we have all the expertise in the room, we understand what the problems are, but we really need to improve access to people in other primary treatment centers, other clinicians who are facing similar dilemmas and are asking all the same questions, but we're not really joined up. And so we said we need a national MDT, one, to improve access, quick, easy access for clinical and laboratory expertise. And just by making sure that we put something at a national platform would immediately help clinicians and the wider group for this rare disease to pop up in the minds far more often than one would ordinarily expect, because there is this national HLH-MDT, there is a group you go to, and having attended those meetings, there are presentations that I have seen before, and actually, in retrospect, that child may have had HLH. And I think it's an empowering MDT in terms of spreading and disseminating knowledge in order to ensure there's early recognition and early referral to specialist centers. And very importantly, as I said, because this is a disease that there isn't a single diagnostic blood test that one can do, it's a host of laboratory tests and specific genetic tests that need to be done. People are often unaware of what tests to do, where to send it to, and what are they asking for. And so we said we really need a forum where we can facilitate accelerating diagnostics. Then we asked our questions, who should be in that MDT? Should it just be the hematologist or just the immunologist? And we said, well, that's not really going to serve the purpose. What we need is engagement from multiple specialties. And we've been really, really fortunate that not only from Great Ormond Street, but across the country, we have had good engagement from hematologists, immunologists, the immunology labs who provide crucial diagnostic information, infectious diseases, rheumatology, neurology, hepatology, intensive care, metabolic care. And this is just to name some core specialties that we have really approached to harness their expertise and their advice on the clinical presentation or the management when children present with their specific symptoms. We made sure that we had national representation, and this was not only from a single primary treatment center, because we think that strength comes from numbers and with broader engagement, especially in rare diseases. And we also wanted to ensure that we had rotating co-chairs so that it didn't feel that this was one team and one group doing it, and there was a shared ownership in making sure that we sustained this initiative long term, and this wasn't a one-off phenomena done for a couple of MDTs and then fallen by the wayside. When was a very important question, because for a rare disease, we would say that, in the UK, I'm sure with genetic sequencing, our understanding of this disease will improve far more. But, we would say in a year in the country, probably 6 children at best, at a push 8 children a year diagnosed with primary genetic HLH. But we also knew that there were a far greater number of children where the diagnosis was being considered, and often therapies needing to be given to calm the hyperinflammatory phenotype down. So we said we need to make it accessible, that it's twice a month, but it just provides that sort of almost a drop in, I've got a child, can I run this by you? I'm a bit concerned, and something that really helps those clinicians when they are scraping the barrel of diagnosis and saying, we're not coming up with anything here. Do you think this child might have HLH? And obviously, COVID has allowed us to live in virtual reality and our virtual platforms, which have been, as we are doing this MDT, right, as this meeting now. And we created an MDT template, and we made sure that we minuted the discussions. Terms of reference are really important with national MDTs, and I would say this quite strongly because I think that people often feel that a national MDT is going to provide the right answer, what needs to be done. And exactly, we were very clear to make sure that the people who sent, all the clinicians who sent the patients to be discussed, as well as the people who were giving advice, were comfortable with the terms of reference of this MDT. So most importantly, what was the criteria for referral? I won't read those out. You can sort of read them and see that those were the sort of, you tick the box and say, I'm asking for diagnostic testing for suspected HLH. I'm struggling. I don't know whether I should start the child on HLH 94 or 4, or whether I could get away with a chemo-free approach, or my child is on the treatment and is not responding. The response is inadequate, or the child is not responding at all, or should we be transplanting the child, and what's the best transplant conditioning, and or if there were treatment-related complications. So it was a fairly broad sort of criteria for referral, but we did want people to put their thinking caps on to say, what exactly is the question you're asking? And that's really important to spend some time on that, because with a disease that isn't clear-cut from the start, the questions have to be very clear. We also made sure that the recommendations would take into from the national MDT would almost always build on local MDT input. What did the local team feel needed to be done, or what was the local opinion? This wasn't to disempower people from understanding or acting on their clinical instinct and their judgment. It was to strengthen it. So we wanted to know, what did the local MDT come back as their opinion? And as a national MDT, our view was to support local MDT decisions, or to reflect on a consensus view from a broader group, making sure that there were areas of lack of evidence, uncertainty, not knowing what to do. And what we were trying to do was to say, we support your view, or we can see that this is a challenging decision, but in our kind of joint MDT, we think this is the best way forward. Making sure that there is no right answer when you're in a situation where there is a lack of evidence and uncertainty on whether the intervention is going to lead to the desired outcome that you want. And more importantly, I think increasingly, and I think Austin will address this in his talk, which is access to novel therapies. At present, there is no research trial recruiting patients with HLH onto a novel therapy platform at the present in the UK. I'm sure Austin will tell us otherwise if he has of others on the horizon. But sometimes if you do want to access novel therapies, it is worth bringing the children and presenting them to the MDT, because if the MDT feel that there is some evidence and some data to back that approach, you can request for compassionate access, saying that this is a national UK opinion, and then approach pharma if they would agree to give you the drug through compassionate access, or ask your local NHS trust to fund it, because that seems to be the only way to improve the outcome of the said child or perceived way. Feedback to families is incredibly important with national MDTs, because the families want to know that they're getting the best advice and the best expertise, especially when faced with their child with a rare disease. So the families are informed by the local clinicians of the national MDT recommendations, but we always put the proviso that the local clinicians are best placed to make diagnostic and therapeutic decisions. Once again, this is because we're making this in conjunction with the local clinicians. We're empowering them, but we also don't have the child in front of us. We are not there to see the dynamic changes in the child's clinical phenotype on a day-to-day, on a week-by-week basis. But we provide advice and support, but the people best placed to make the decisions are the local teams. And we always encourage feedback to the MDT. James will allude to this in his slides, because he is chasing all the centers, asking them for feedback on the recommendations that were made. Were they considered? Were they followed? What was the outcome of those recommendations? Did you get a confirmed diagnosis? And how the child is doing. Wider engagement is really important and the strength of our MDTs come from wider engagement. So apart from the specialties, that long list that I gave you, we always ask for other specialties to drop in if there are specific questions that relate to their area of expertise. So if you have a child with CNS HLH and you're looking at these scans and you're not sure whether this is an infection, an inflammation, a vasculitic phenomena, we have radiology experts in HLH who would more than willingly come to the MDT and give their opinion on their experience of looking at neuroinflammatory HLH. That's just one example. You could ask a respiratory team. So we have the ability or the flexibility to engage other specialties depending on the question being asked. We have had international referrals from further afield outside the UK, and I think that is useful at times, and at times perhaps not useful. We don't want to limit our MD to just a UK approach, but sometimes some of the questions that are asked may not be relevant or may not be easily achievable in international countries. So sometimes we can give advice, international referrals and advice, but that at times might be better via email or better via individual case-by-case discussions. We haven't had that many international referrals, but we have had a few that have come through to us. Very importantly, and you'll hear from Jessica Manson and Rachel Tattersall, that we collaborate with HIHASC, because I think the cross-pollination across pediatric, adolescent, adult HLH is very important. Treatments that they use in the adult world may have an impact and may improve the outcomes of children with HLH, or stuff that we do in pediatrics may improve the outcomes of adults with HLH. So I think this cross-pollination across pediatric and adults is really, really important. At times we've had patients coming to our MDT and we say, actually, I think this patient is would be served better if they were discussed at HIHASC, and vice versa. Claire will speak a little bit more at some point, but we want to make sure that we have, rather than a UK registry, but contribute to a European-wide registry for genetic HLH, so that we actually have an epidemiology of how many patients with genetic primary HLH are in the UK, and what does that look Europe-wide. So I'm going to stop talking now. I'm going to hand over to James. James, I'll keep moving the slides and you just have to say next as you move on.
Thank you so much, Anu. I'm James. I'm one of the pediatric hematology registrars who I looked at basically at the minuted data from the MDT over the last few years. So it's not got a complete data set by any stretch of the imagination. And only records cases that were referred on to us. So not every case would have been referred. And the data set is in two parts, really, in the fact that there was a local MDT between May of 2015 and 2022 that did invite people from other centres to contribute, but wasn't formalised until March of 2020. So in the entirety of documented time, we've got 71 cases that were referred to us for suspected primary HLH or something that needed some input from the team, with 48 cases since moving to a national level, a more formal basis. Of those cases, looking through the data, 39% were confirmed to be primary HLH with a genetic cause, which is a number of 28, of which 17 were actually referred in with the diagnosis made, but requiring discussion of ongoing management options and how best to move forward. There were a further 7 cases that were felt probable, but there hasn't been any feedback to the MDT about whether there was a confirmed genetic diagnosis made after that place in time. And then of the secondary cases, of which 21 cases were probable or likely secondary, 5 were malignancy associated HLH and 8 were macrophage activation syndrome, so associated with a rheumatological diagnosis. And then a further 21% were felt probably not to be HLH. I haven't divided that one down. Some were fed back as very much confirming not to be HLH by another cause. Others did not have confirmed data. And of note, there were 6 cases that had of primary HLH that had isolated CNS symptoms at referral, which was of interest. Annie, can we just move on to the next slide, please? This is a summary of where those referrals came to over time, and there will be a disproportionate representation from Great Ormond Street because of those first few years where there was more of a local setup. So this is all the cases since 2015, but you can see that there's a wide array of cases from across the country, and we'd always invite more for anyone who's interested going forward. And you can note that there are some international referrals there, which were discussed as well, as Anu alluded to. Moving on to the summary of treatment once we've got the diagnostics. The data set is not always clear from the notes, particularly because people were often referred in at a later time point, looking either at stem cell questions or at sort of refractory cases. So it's not always entirely clear the sequence of treatment. But from the data set I was able to analyze, from first-line therapy, 4 cases were able to be treated with steroids only. These were actually normally the CNS-involved disease only, or patients who were stable but waiting for further, more definitive treatment and didn't require very strong arm sort of immune modulatory therapy. 17 patients were treated as per the HLH protocols, including steroids or cyclosporin and etoposide. And a further 7 I had no data for as to what was given for first-line therapy. When it came on to cases that required further therapy, anakinra has been used in 12 cases. And then we come on to where I don't have strong confirmation of disease. I only have the MDT outcomes, looking at recommendations. Campath was recommended in 6 cases. Ruxolitinib was recommended in 2, and emapimolab was recommended in 3 cases, although it was not entirely clear whether that was accessible. Cases were made for compassionate use. And it's not entirely clear whether that was able to be accessed. When it comes on to this question of stem cell transplant, of the 28 cases that were confirmed primary, 19 cases were recommended for referral for stem cell transplant. There were a few cases that were recommended for holding for various reasons, but there are a significant number which I do not have data for as to what the recommendation or eventual treatment was. Unfortunately, I only have outcome that one of those cases actually received stem cell transplant, so that will be part of the ongoing work to find out which cases went on to have stem cell transplant and what the overall outcome was in those circumstances. And then in terms of conclusion recommendations, it was very clear looking through minutes on a monthly or bi-monthly basis, going through time, the sort of referrals that were coming through, and it was a progression over time of those questions coming in, and quite often it was looking for confirmation of a rare diagnosis, or at least a consideration of the differential diagnosis in a very complex cases, and often very difficult cases where people are asking for some help in terms of what diagnostics should be sent, anything else that should be considered. And it was, I think, a very valuable forum to look at those questions. And quite probably in about half of cases or more, there was the discussion around complex management decisions, particularly in the absence of a strong evidence base or any strong guidance, and also evolving therapies and when they should be used, particularly in cases where things aren't responding or are heavily nuanced and needs some very, I think, some lots of thought. So it was a really interesting way of viewing those decisions over time and trying to see where consensus can be launched and where sometimes it just requires considered opinion and discussion to work the way forwards. I think also this was potentially a very unusual situation where there is actually a collection of a relatively large case series of referrals down this line for a rare diagnosis, including, sorry, forgive me, my series going crazy, including the ability to collect data around how patients are presenting, including those who are having isolated CNS presentations or even just odd manifestations of the same neuroinflammatory conditions, and also looking at management and hopefully outcomes going forward. So a big part of, I suppose, our plea going forward, it would be lovely to look at the retrospective cases and look at a bit more in detail at that data set, to look at the confirmed primary HLH management cases and the diagnostics and their management and outcomes, to see if there are any trends that we can use. And we're going forward, we're going to continue to collect this data for the meeting held every 2 weeks where we discuss these cases, trying to make sure that you're all aware of this so that we can have that conversation moving forward and try and understand these cases going forward as well.
Thank you, James. So I hope James has charmed all of you enough to say that when he then sends you an email in your inbox saying, please, can I have the outcomes of these children and I need some more information, please do respond to his email, because as I've said, this is a team effort and this isn't something that one team and one person can do, or one person can do. So I think the question is, this MDT has run from March of 2020 and will continue to run. We've done this for 2.5 years, and touch wood, we still have had good engagement and it hasn't fallen by the wayside, as all good initiatives do and then fall, but it hasn't, which is good. The question that we are asking ourselves is, having collected this data, which we will have more information on, what are the things that we need to do to move the field forward? Firstly, and most importantly, diagnosis and making a diagnosis. Recognition and diagnosis are two very important things, and that's sort of we have to get right from the get-go. And so we're working on, the HLH MDT group are working on guidelines for on the sort of UK approach to a newly diagnosed child with HLH or a clinical suspicion of HLH. What are those diagnostic tests, primary and secondary HLH tests that you would do? The second area that we feel that HLH in terms of therapy hasn't really moved on from HLH 94 to HLH 2004. And this is a rare disease which really needs access to novel therapies. And I really look forward to hearing Austin's talk on novel treatment options in HLH. CAMPATH has been around for a very long time, but there is, and certain centers, certainly in France, have been using CAMPATH up front in HLH. And I suspect that at some point we too need to begin to have those discussions about which children would we prefer to use CAMPATH up front, and then what is that interval between use of CAMPATH to transplant. Ruxolitinib is another interesting novel agent. Separate to this, based on our group MDT, we have Dr. Salah Ali, who is in Leeds, who is doing a retrospective study on time to transplant in children with primary HLH, because we know that with HLH, all we are trying to achieve with the chemotherapy and steroid backbone is to achieve a period of optimal disease control to get the child in the best possible clinical state to a transplant. And it's defining what that optimal disease control is and what is that time to transplant and whether that impacts on the overall outcome of children. So Dr. Salah Ali is leading on that, and he has asked for feedback from centers on their retrospective patients for those who did or did not get a transplant and what their journey was. We also are feeling that in view of the neuroinflammatory HLH patients that we are being referred, that we do need consensus on the treatment options for CNS HLH. This is an increasingly interesting area because these children do not have systemic HLH, they have isolated CNS HLH, and it's about if there is any role for systemic therapy or should it all be CNS-directed therapy. The unmet need, and this is really probably the most important bit of this talk, is what is the unmet need in this rare disease HLH? Most importantly is we need a study. We need a study that recruits patients looking at novel treatments in HLH. And for that, you need pharma engagement and you need patient and public involvement to really push that agenda forward, to say that, and it has to be a joint approach. The clinicians are willing. We need pharma and PPI to get on board and to say, we need a study. What are the promising novel agents and how can we improve the outcomes of children with a chemotherapy sparing approach? And more importantly, it's a rare disease. If we say we get only 6 to 8 or possibly 10 children a year, real progress in a disease cannot be made unless you have global collaboration. And I think that's where we need epidemiological studies, identify genetic subtypes, and then try and see how you can optimize outcomes within those genetic subtypes of HLH. And I'd like to end my talk and James's talk to say that these are the acknowledgements of some of the clinicians, and by no means is this an exhaustive list of clinicians who have actively contributed to our HLH MDTs. We are very keen on having more people involved if they have areas of special interest or expertise and would like to join our MDTs. And most importantly, our biggest thanks goes to the families and the children. We're constantly learning from them with regards to atypical presentations or how they respond to treatment, because the more challenges they present, the more we learn as we go along. Thank you.
Thank you so much, Anu and James. That was a beautifully clear presentation, and I think captured perfectly the spirit of the MDT and why we need it and what we hope to learn from it. I can't see any questions that are related to your talk specifically on the chat. So, but I suspect that there may be some more that come in a little bit later. But I would like to take the opportunity myself as well to really encourage people to join to contact us if they want to be involved in the National HLH MDT and spread the word amongst colleagues that we are a friendly bunch who are very happy to listen and offer as much advice as we can. And we really do have a collective experience amongst the many different centres that attend that I think can be very useful. So thank you so much for that. And I'm going to move on now. It sort of segues perfectly into Austin's talk. So Austin Worth is a consultant immunologist at Great Ormond Street Hospital with a very long-standing interest in HLH and its management. And he's going to give us a talk on the novel therapies that are being used in HLH at the moment. Thank you, Austin.
Thank you, everybody. Thank you, Anu. Thank you, Claire. And I feel I've been built up a bit excessively, but I'm hoping that we can just talk through the sort of therapies that we have available to us at the moment, and put out some thoughts about where some of these therapies might sit, and also reiterate really the call for better studies that are going to allow us to take treatment to the next level. Oh, there we are. I do have a couple of disclosures actually relating to this, which has been some work actually developing educational material related to HLH. So as everyone here knows, familial HLH is a primary inborn error of immunity, which the best described and the first described conditions relate to genetic defects of cytotoxicity. So cytotoxic T cell cytolytic granules are blooded from the Golgi apparatus and then sit waiting to be primed before they're released into the immune synapse. And we know many of the disorders that lead to primary HLH are caused by defects in this complex and highly regulated process. And those genes are isolated in this diagram. And what does that mean? Well, in a normal patient, when you have cytotoxic T cells trying to eliminate a virally infected cell, and for the sake of ease, we're talking in this diagram about a virally infected macrophage or monocyte. The CTL interacts with the macrophage or the infected cell. It releases gamma interferon, and as a result, you get a formation of an immune synapse between the cells, resulting in non-necrotic cell death, apoptosis, and elimination of the viral infected cells, with a termination of the ongoing viral replication process going on in the virally infected cell. However, in a patient with HLH, you have a breakdown of that communication between your cytotoxic T cells and your macrophages. And as a consequence, both sides of that discussion get very angry. And you get cytotoxic T cells churning out lots and lots of gamma interferon, which make the macrophages more and more activated, and they in turn produce more and wider spread systemic cytokines, which drive both a local and a systemic inflammatory response, which leads to a positive feedback loop that goes completely out of control, leading to the pathophysiology of HLH. To make things worse, these cytotoxic T cells will proliferate, and the cytokines will make them much more resistant to apoptosis and switching off their immune response. So in recent years, there's been a lot of work conceptualizing HLH, and I feel actually the area now is in a much more sensible place in terms of thinking of pathophysiology, and rather than thinking of separate disorders of primary, secondary HLH and macrophage activation syndrome, we can think of these disorders as all part of a much broader spectrum that involves a lot of hyperinflammatory processes. At the primary HLH end, you have the primary problem of ineffective cytotoxicity, leading, as we were saying, to an excess of gamma interferon. And that can be driven by infection, or it can be driven by malignancy. But at the same time, our rheumatology colleagues are much more used to seeing a similar process being driven by autoimmunity, often with pattern recognition receptor signaling that becomes dysregulated, TLR9, and resulting in activation of the inflammasome, which then produces high rates of IL-1 beta and IL-18, which again leads to the same cytotoxic storm. And this then leads to systemic cytokines such as IL-6 and IL-2. And then the net result of this is a wide range of different pathologies that we see overlap with primary HLH, with all sorts of disorders. And as everyone here is very familiar with the early discussions during the COVID pandemic, I think everyone who'd managed HLH could easily see the parallels between what was going on in these patients and what we sometimes saw in some of the more atypical patients that we look after. So having this understanding, So just going back to where standard treatment has got to. So when, again, I'm sure you're all very familiar with this, when the results of HLH 2004 were published, it was in reality very disappointing because there hadn't really been any progress from the 94 protocol. And the overall 5-year survival rates were still pretty dismal at 62%, with a pre-transplant mortality of 20%. So that's 20% of patients that we can't get to a state that we can get them to transplant. And then, further poor outcome afterwards. And in reality, and particularly for primary HLH, there was actually no change in the outcome between the two studies. And that's summarized by these survival curves, which show you the overall outcome. And then if you subdivide it into primary and secondary HLH, you discover that, and compared to the 94, although there was a trend towards a slightly better outcome that was non-significant in the 2004 study, actually once you use the same criteria for classifying patients with primary HLH, that difference completely disappears. And essentially, as has been seen in many of these studies, it's robbing Peter to pay Paul. You can get children into better remission using more immunosuppression, but you pay the cost in terms of infection. So if we go back to our model of pathophysiology, where do our current treatments sit, and what are the new treatments out there, and how do they work? Well, the first thing that we don't often talk about, but is very clearly important, is if you have an infectious trigger or a malignant trigger or an autoimmune trigger, it's getting rid of that trigger. One of the more common triggers, particularly in children, is EBV, and rituximab is a highly effective treatment for that. So we shouldn't forget that. Of course, the backbone of all treatment is steroids, and steroids affects everything and is a very effective treatment. So, I'm not going to say anything more about steroids today. So etoposide maybe gets a bit of a bad press these days, with everyone desperately trying to find new drugs that stop us from using etoposide. But of course, there is a track record of etoposide being very effective, and its predominant effect is on the macrophages, although it will also impact on the lymphoid lineages as well. And by taking out one of the main cells in that abnormal communication, that's the mechanism of working. But as we've understood the cytokine storm much better, we have some targeted antagonistic monoclonal antibodies that we can now use. And IL-1 beta is the first of those, and anakinra is very, very established, that many of us are quite familiar with. Of course, measuring levels of IL-1 beta are very difficult because it's predominantly an autocrine cytokine. So therefore, you don't classically it's very difficult to detect high levels in the systemic circulation. And I'll talk a little bit more about blockade of IL-18 and IL-6 at the same time later on in the talk. And one of the more exciting areas is rather than actually targeting the cytokines themselves, but targeting the signaling downstream from the cytokine receptors. And this is a new group of drugs that have been around for a little while, but are relatively new to treatment of HLH, the Janus-associated kinase inhibitors, or JAK inhibitors. We've also now got an inhibitor of the main cytokine that, from a primary HLH perspective, seems to drive that, and that's the main communicator between T cells and macrophages, gamma interferon in amapalumab. And then we've also mentioned Campath already, alemtuzumab, which is effective, not in a dissimilar way to etoposide, at taking out all of the immune cells that are driving this inflammatory process. And then I'm also going to mention another therapy that neurologists are more used to using, called natalizumab, which is a completely different concept of how treatment might work, which is working by trying to separate the cells that are driving this inflammation from each other. Okay, so I'm going to start with anakinra, although I'm not going to say very much about anakinra because it has been around. And probably the most important news about anakinra is that it is now commissioned in the NHS due to a lot of the adult physicians who did a fantastic work 3 or 4 years ago to really drive this forward, which has been great for all of us. Of course, as a paediatrician, I love the way that we have an all ages commissioning policy, except for the fact if you're under 10 kilos or under 8 months of age, because presumably that doesn't count for all ages. So it is still uncommissioned in that area. And actually, as part of the nice commissioning position, actually there was a lot of flexibility about being able to use the anakinra. And that's despite the fact, actually, the evidence for anakinra remains actually very poor. There are no comparative studies in the literature, and probably the only study that has any sort of comparison is an adult study that is a subgroup analysis of a large sepsis trial, which went back and looked at patients who fulfilled the criteria for macrophage activation syndrome and looked at those who received anakinra and those who didn't. And there was a significant hazard ratio for those who had placebo over anakinra for that, supporting some benefit in this sort of setting. But overall, the evidence for efficacy for anakinra is poor. However, it does have an awful lot of benefits, and this is why many of us quite like to have it in the armory. The first thing is that it has a very short half-life, so if you're starting it, it will switch on quite quickly, but you can also get rid of it fairly quickly. So if things go wrong, you can reverse the impact fairly rapidly. It has all of these monoclonal antibodies have a side effect profile that we're learning about more and more. But actually, overall, I think most of us feel that anakinra is generally very well tolerated. We do have patients who develop cytopenias, and particularly liver failure at around sort of the 2nd to 3rd week of treatment that you need to keep your eyes on. But actually, in our experience, we've only had isolated and occasional cases who've run into trouble with that. And actually, with more and more use, we're becoming more familiar with its use, and there are various modes of providing it, both intravenously and subcutaneously. It is quite painful, but given subcut, but I think compared to everything else, that's probably something we'd have to accept. So the next novel therapy I was going to mention is blocking IL-18. So as we've learned more about the pathophysiology of some of these primary disorders, there are clearly a group of inborn errors of immunity which give high rates of HLH that don't follow the classical cytotoxicity defect pathway. And the maybe the best understood of those is ZIAP deficiency, but we're increasingly finding that both monogenic mutations, but also genetic susceptibility genes in the regulators of the inflammasome, of which the NLRC4 gain of function mutation is maybe one of the better described. And even more recently, we've had conditions like CDC42 described that have essentially upregulation of an unregulated activity of the inflammasome. And with ZIAP is a complex signaling protein that sits in between several different cellular pathways. It has a role in inhibiting apoptosis. It has a role in pattern recognition receptor signaling from innate stimuli, but it also has a role in putting a brake on inflammasome activation. And as a result, you get particularly high levels of IL-18, suggesting that your IL-1 beta levels are also very high, as the two cytokines come from the same gene transcript, so one should be produced at the same rate as the other. And this leads to both HLH and inflammatory bowel disease. And as a result of this combination, much of the early work around transplant was really quite concerning and was associated with very high levels of mortality. But a paper last year from Arnold et al. Kind of summarized the sort of much of the world data from some of the centers that have done a lot of ZIAP transplants. And actually, we now believe that actually if you can get through a transplant without GVHD or with just low levels of GVHD, actually your outcomes can be very good, and that the outcome data is skewed by those patients developing high levels of GVHD, grade 3 and grade 4. So even more important to make sure you've got these patients really well settled and the inflammation under as best control as possible before going into transplant. So tadakin alpha is an IL-18 binding protein antagonist, which results in destabilizing the stability of systemic IL-18, leading to its increased degradation. And there is a small study that has been sort of published, which is was the pilot study to an ongoing study looking at treating patients with NLRC4 gain of function and also ZIAP deficiency. And here you can see on the left some of the inflammatory markers with CRP, ferritin, coming down nicely and in response to initiation of treatment, the measurements of the IL-18. The top panel is in serum, but also CXCL9 in response to that, which CXCL9 is a cytokine that can be used as a surrogate of gamma interferon levels in the serum. All of those coming down in response to the ferritin here. And they also looked at similar levels in stool, which were also seen. And within this study, there was a couple of patients with ZIAP also treated, and just hot off the press earlier this year, there's another case report from the US of using tadakinin alpha to treat ZIAP deficiency. Okay, so moving on to the sort of next cytokine we could talk about. So tocilizumab, IL-6 blockade, so much more of a systemic inflammation cytokine. Again, in the COVID pandemic, most of us have got much more familiar with it, both using it and the literature around that. Certainly historically, IL-6 was thought to be a sort of downstream product from IL-1 beta receptor signaling, although I think that's probably a simplification now, and I think these are all much more complex cytokine networks in reality. There is much less data of its use in HLH, and most of that is in adults and in secondary HLH. And although its use has been discussed extensively, there is much less published data around that. It has some licensed indications in terms of in systemic onset GIA. Excuse me. And also with some other autoinflammatory disorders in early childhood. It has a much longer half-life and therefore is much less reversible than anakinra. But like anakinra, it generally has a fairly good side effect profile, and particularly seems to be less severe in terms of infectious susceptibility. And unlike anakinra, we have a direct biomarker, the serum IL-6 level, that is much more available to monitor in labs up and around the place. Admittedly, it's not as available as the CRP, but actually the CRP does follow very carefully with the IL-6 levels as well. So it's quite reasonable to think about that as a biomarker for this. So what data is there published for that? Well, not very much. This is a study that described a cohort of 9 adults with secondary HLH who generally responded well, with 8 out of 9 of them clearly making a response to HLH and only 1 remaining refractory. Although probably reflecting the nature of the secondary conditions, the overall outcome in these patients was still very poor, with approximately half of them dying. A second larger study that's just come out this year shows much more clear and negative results around this. So this was a case-controlled cohort study comparing tocilizumab to standard of care, and actually showed a much worse outcome for patients who were treated with tocilizumab, both in terms of their response data biochemically and clinically, and also, as you can see at the bottom there, with a marked worse survival for those who were treated with tocilizumab. So in terms of where does that leave us? Well, I don't think any of this is desperately positive data. However, I think that this is still a drug that is available in most hospitals for other indications, and we do have familiarity with it. So in highly selective cases, I think there may be a role for turning to tocilizumab, and certainly I've had one very specific patient that I've been involved in the management with, where they had a really good response that was highly beneficial to that individual. So perhaps there is a role in very specific cases for salvage. So the next very exciting cytokine blocker is gamma interferon, which for many years now, I would say for 20 years, we've been waiting for this study to come out, since the early mouse models suggested that blocking gamma interferon could completely reverse the models of HLH in mouse models. The study which I'll present came out in New England Journal of Medicine in 2020. So gamma interferon and emapalumab is a humanized anti-gamma interferon IgG1. It binds both receptor-bound and free gamma interferon with an antagonistic effect. I've also already mentioned that although gamma interferon can be quite difficult to measure, we can use the sort of longer half-life of the CXCL9 in serum, which can be used as a biomarker for this. However, there are a couple of things to point out. I mean, one, as you would predict from the models of pathophysiology now, there's enormous inter-individual variability in the levels of production of gamma interferon in terms of log levels of variability, and also within the same individual as well. And this is from a PK study that ran alongside the clinical trial that was actually showing the risk of developing adverse reactions with the exposure, the drug levels. And actually, paradoxically, the higher the levels that patients got, the lower the risk of adverse reactions, suggesting that actually you do need to be quite tight about how you're dosing these patients, and that there is a real risk of underdosing patients around this. The severe adverse reactions, as you all know, for when you're treating patients with HLH, it's impossible to tell whether or not it's a reaction to the medication or it's just part of the disease process. So I think my interpretation of this is that the higher the dose, generally the better control you got and the fewer adverse outcomes you got. So the trial that we're talking about followed patients with primary HLH. There were two arms to it. There were previously untreated patients, so using emapalumab up front, and the trial started with using patients on salvage therapy. With the salvage therapy, physicians were allowed to continue the existing therapy that had already started, and both arms used dexamethasone in conjunction with emapalumab. And the outcomes showed some sort of benefits. If I bring you to the graph in the top right-hand corner, the overall response refers to a combination of complete response, partial response, and biochemical or a response of the HLH biomarkers that we're looking at. Having said that, maybe the overall outcomes were not as large as we'd been hoping for when they came through. And you can see that overall survival rates going through to transplant were still running at just about 70%, which is clearly better than the sort of high 50s, 60% seen in the HLH 2004 trial, but probably is more equivalent to some of the more modern outcomes that we've seen in larger cohort studies looking at other agents. And actually, I think the consensus from this was that this is a very good drug for some people, but it isn't a cure-all, and that there are patients who clearly seem to be refractory to this therapy. So where are we now with this? Well, in the US, it has become FDA approved, and therefore there is increasing use of it, and people are getting much, much more experience of it. However, in Europe, the EMA and both NICE rejected applications for licensing, feeling that there wasn't enough additional benefit for using emapalumab over existing treatment. And it would be a really helpful drug to have on a compassionate basis, just because, as we all know, when your backs are against the wall and everything seems to be failing, the more different modalities you've got and you can try on an individual patient kind of makes us feel we have tried everything. But at present, that isn't available, although I have heard rumours that there may be some movement in that in the future. Okay, so I'm going to move away now from cytokine blockade and start talking about serotherapy. And much of this work originally came from the ATG work that came out of Paris from the Necker. And this is quite an old publication that I'm sure you're all very familiar with, a single center retrospective cohort study looking at 38 consecutive patients who were treated up front with ATG in combination with steroids and cyclosporin. And if they had a CNS HLH, they had IT methotrexate steroids as well. And essentially, in summary, what they found was quite high rates of remission, better than in the HLH 2004 studies. However, very high rates of infection, and overall, there didn't appear to be any sort of benefit from compared to the Histio Society studies. However, with the encouraging results of this being able to get children into study, there have been more clinical trials set up around this, and the HIT HLH trial is still unpublished, and I know there have been some concerns about how good the data is going to be, but we'll wait and see that data when it comes out. So a lot of the feeling was that the reason ATG maybe was not quite so good was that it's very stimulatory, and actually giving something that is actually activating T cells before they die to patients with HLH may be counterintuitive. So a logical progression to that was to use Campath or alemtuzumab, which is a humanized monoclonal antibody to anti-CD52. And this produces a rapid and prolonged lymphocyte depletion via a number of different mechanisms, both direct cell cytotoxicity, ADDC, and also inducing apoptosis. It targets T cells, B cells, and macrophages, and there's obviously quite a lot of experience of it as it is licensed for multiple sclerosis and for treatment of CLL. But paradoxically, it can cause quite severe secondary autoimmunity, and also there are occasion cases of it actually causing HLH in treatment in adults as well. So this first came to the first big publication of using alemtuzumab was from Rebecca Marsh at Cincinnati, where she presented 22 patients who they used alemtuzumab as first-line salvage therapy of patients who were not responding to HLH 2004 treatment. What I would say looking at that data is that it was probably used at quite an early stage in terms of salvage. So to be able to being described as failing treatment, you needed to have just one ongoing clinical feature of HLH and evidence of either a raised ferritin or a raised soluble CD25. And certainly in our experience, the CD25 seemed to take quite a long time to settle down. So I think there's probably quite a degree of leeway in who got this. The outcome data, considering this was a set of refractory patients, showing that over 75% of them made it to transplant, was, I think, a very good outcome at the time and very encouraging. And associated with that, many of the sort of biomarkers clearly showed responses with increases in neutrophil counts, reduction in abnormal LFTs, reduction in ferritin, triglycerides. And with this, and bearing in mind this is a salvage therapy, so it's patients who are not responding, so you've lost the best outcome patients, an overall survival of over 65%, I think is probably not a bad return in that sort of setting. The team at the NECA have taken on using alemtuzumab as upfront therapy as an alternative to their previous ATG strategy. And they have done this in two steps, one as a pilot study, which has been presented extensively over the last 5 to 10 years and also published in sort of abstract form. And they now have a data from a prospective study, which as yet has not yet been published. And the data that is out there is extremely good. If you see the diagram on the right here, this is from the pilot study. They took 26 patients. They used quite high doses of Campath, so a single dose, usually starting at 4 per kilo. They used cyclosporin alongside that and a relatively short course of methylprednisolone, which they aim to start to wean down from day 4, getting down to sort of quite low levels by day 14. And then their model of care is to go fairly rapidly to transplant using lots of haplo-identical transplants and not worrying too much about specific donor. For those who don't go into remission with a first course, they then give a second course, and in some cases have gone as far as giving a third course. And in the pilot study, they ended up with a 92% survival rate, having gone through transplant, although not all of those patients had been followed up for a long enough period of time to say that's true TRM. But yeah, very, very encouraging results, and that is why many of the centres in other countries, including centres here, have thought about trying to replicate that. So the next new kid on the block is the Janus-associated kinases, which are very trendy at the moment, particularly in the sort of immunodeficiency world, in that I think we're wanting to try these out on all sorts of our immune dysregulatory disorders. So many cytokine receptors use the JAK-STAT pathway to signal, and this is a cell biological system whereby each individual cytokine receptor uses a different combination of the 4 JAKs, which dimerize, and the specific dimer then determines the specificity of the STATs, which are phosphorylated and activated, and the STATs similarly dimerize with 7 different STATs, which can dimerize in different combinations to give different differentiation and outcomes for the cell. So a very complex regulatory pathway. But because of the homology between the STATs, there are drugs which could impact on these. And as you can see from an HLH perspective, all of these cytokines all signal via the JAK-STAT pathway. And therefore, you're not just hitting one target like you are with anakinra or tocilizumab, but you're actually potentially targeting across the board. And there are a number of JAK inhibitors that have been out there and are licensed for a number of different indications. The one that in pediatrics and that we are most familiar with is ruxolitinib, which is one of the earlier JAK inhibitors and actually has quite a broad specificity covering both JAK1 and JAK2, which in this setting can be quite an advantage. There are, I think, of the others out there, it is worth mentioning baricitinib, specifically because it is not metabolized through the liver and is just urinary excreted, and therefore for patients with liver failure you're going to get a more reproducible blood level without adding to liver toxicity. So that is a drug that I think is worth just thinking alongside. It doesn't have quite the same broad degree of action as ruxolitinib does, and it seems to be a bit more targeted and high affinity. So these drugs, as you would expect, would have quite a severe side effect profile, and actually it's more surprising at how well tolerated they are generally. So undoubtedly immunosuppression is an important side effect, and VZV, BK nephritis, and JC encephalitis are the infections that we particularly worry about, as well, of course, mycobacterial disease, which we're always concerned about in these settings. And I think they clearly are more suppressing than anakinra and tocilizumab, but maybe not as much as some of the other chemotherapy agents, and certainly not as much as Campath and ATG. You can also get a bone marrow suppression with thrombocytopenia. Some patients get diarrhea, and then the usual sort of abnormal LFTs and such things. There is a big concern about what the long-term effect of taking these drugs would be in terms of malignancy. And there is also a feature that's been seen in treating patients with primary immunodeficiency that if you stop it, you quite regularly get quite a severe rebound of hyperinflammation afterwards, which can be a lot more difficult to treat than the original disease. So we do need to be careful about using these drugs unless you're going straight into transplant, which would resolve that problem. And since these medicines have come out, there's been a whole flurry of case reports of using ruxolitinib in primary HLH, secondary HLH, children and adults. However, these are all very descriptive, but don't really take us forward in terms of where this is positioned and how efficacious it is. However, just a couple of months ago, a first study of reasonable size has come out looking at a upfront ruxolitinib based regime, and this is an interesting study design actually. So these patients, what the team did is they were allowed to start dexamethasone as first line, but once they decided they had HLH, they were recruited to start ruxolitinib, and then they had quite strict assessment points from very early times, from day 3. And if they were failing therapy at that stage, they continued on the ruxolitinib, but they escalated to more conventional therapy, usually higher doses of steroids and etoposide. And therefore, they had two arms from this: those that were kind of just remained on ruxolitinib monotherapy for 28 days, and those that had combination therapy. And actually, the outcome data was very good, with 83% overall survival and no severe adverse reactions that they found. And they found that actually the ruxolitinib was very well tolerated. They actually did not report anybody who didn't respond in one way or another, which always sounds quite suspicious. Unlike most of the survival curves we're seeing, they're actually showing event-free survival as a curve. And usually when you're talking about HLH, there's so many events that that's a bit of a depressing curve to look at. But you can see the overall survival is a stepwise better than most of the other drugs that we've been looking at today. And similarly, those who responded up front to ruxolitinib actually did extremely well, whereas those who didn't initially had a worse prognosis. So this sounds fantastic until you dig into actually the patients they were treating. And this is a study from Beijing. Actually, in Beijing, in China and the Far East, they have very high rates of chronic active EBV. And actually, within this cohort, there were a lot of patients with chronic active EBV or EBV-driven secondary HLH. Interestingly, and suspiciously in terms of how extrapolatable this is to our practice, they didn't mention any diagnostics around primary primary HLH. So we don't know how many of these patients have the sorts of disorders that we're normally looking at. So I don't think it's a like comparison, but nonetheless, very encouraging early data from that. And interestingly, for those who had, if you like, true HLH, they responded much better than that group who had chronic active EBV that had been grumbling on for over 3 months, and we know are a particularly challenging group to try to treat. So where are we now with JAK inhibitors? Well, there are clinical trials going in both North America and in China, which are looking at both either combination therapies or upfront JAK inhibitor first line. They are well tolerated, much better tolerated than you might predict, and but they probably do have more infectious complications than IL-1 blockade. At the present time, there is pretty limited data on primary HLH, but there is more data in the secondary setting. I wanted to highlight this, as well as being an agent to think about in salvage therapy. There are patients who we seem to be unable to treat, but actually, because this is some of these are oral agents, actually we do have the opportunity to potentially send people home on this drug. So I think in that setting, it is definitely something that we could think about at this stage. And just to finish off, Anu had mentioned earlier about isolated CNS HLH, which is a disease phenomena that I think the whole area have just brought together and just sort of much more recognized over the last 5 years. This is from one of the publications of 38 patients across Europe with this disorder. So these patients present without systemic features of HLH, and go on and develop CNS inflammation, often subacutely, but progressively, that either don't respond to treatment or certainly relapse very frequently. Many of them had previous diagnoses of clippers or fires, but now once we have genetics, we recognize that they have a primary HLH disorder causing that. And one of the difficulties is we really don't know how to treat this. As Anu was mentioning, we don't know whether systemic treatment is appropriate. And even in the context of transplant, we know that a proportion of these patients will relapse from a CNS perspective, even with 100% donor chimerism. And that we also know that many of these patients, by the time they get to transplant and they've been diagnosed, they've actually got irreversible damage, making that decision around transplant extremely difficult. So this is a particularly challenging group. But it does offer some slightly alternative ways of thinking about treatment. And there is a drug called natalizumab, which is a humanized alpha-4 beta-1 integrin inhibitor. And this blocks the interaction of the integrins with VCAM1, which is essentially what lymphocytes use to hone to the CNS. So by using this, you can block the penetration of lymphocytes through the blood-brain barrier. And it is licensed in the treatment of severe relapsing remitting multiple sclerosis, and neurology colleagues have actually used this drug with remarkable effect in individual cases for refractory and difficult to treat neuroinflammatory disorders. So we've considered this in a few patients, and on one patient we have used it where we kind of ran out of alternatives, and this was an older patient, so an adolescent, who with perforin deficiency and a presentation of isolated CNS HLH, who we managed to get into some sort of remission, had a transplant, and then despite having high-level donor chimerism, relapsed with isolated CNS disease post-transplant. And in that setting, we've managed to get him back into remission with natalizumab, which we're hoping will hold out long enough for the impact of the graft to kick in to actually change things over. But although he has done much better than we were expecting, it's still early days and just a single case report. But illustrates how some of these, there are new medicines out there that could still be part of our armory for HLH. So just bringing it all together and summarizing, I think there are a lot of novel therapies out there. I think when we're talking about patients who are not following the standard route or patients who are trying to minimize toxicity, there's almost sometimes a confusing array of different drugs we can think of now. What we desperately need is more clinical trials, what I would advocate for is trials that are also going to be being very careful about monitoring the biomarkers, so that I'm sure the way we're going to have in the future is using specific biomarkers to guide therapy. So if we're doing any interventional trials, it's really critical that we look broadly across measures of immunity to see if we can see which treatments are working, which aren't, from an immuno perspective as well as a clinical perspective. As part of that, what I hope we will see is a move towards much more personalized treatment. Already we're able to do that partly with genetics, and the example of Zyme deficiency is a good example of that, but it is still very crude and very much in its infancy. Where I've just been talking about single agents, however, clearly a combination therapy is going to be important. And again, there's a nice a study in JACI coming out that's just come out last month, looking at a mouse model that was investigating uses of combinations, and found that the combination of using elapalimab and ruxolitinib seemed to offer a much better synergy than using ruxolitinib with either anakinra or tocilizumab. So I think there are going to be subtleties around that, and it is important that we think about that in terms of trial designs and where we go with monitoring salvage therapy. And then I haven't talked about transplants, but a lot of these treatments are going to dovetail into transplants. Rebecca Marsh published the use of alemtuzumab at very early before HSCT for patients with HLH as a way of trying to get better control going into the transplant. And we simply don't know the impact of drugs like JAK inhibitors on the transplant process and when we should be stopping. I think CNS HLH, both isolated and as part of systemic HLH, remains incredibly challenging, and there's so little data out there to actually support any of these treatments, even those treatments that are the intrathecal treatments that are part of the protocols. The evidence for them is very limited. And then I think we also have a lot of much more unusual situations that we're dealing with. The concept of isolated organ HLH is coming through. There's a paper from earlier this year talking about acute liver failure in the under 2s as being a presentation of HLH. And I think we will see more and more of these more and more unusual presentations that might need more inventive treatment approaches. And as we are getting patients to survive to a certain level, but maybe not being appropriate for transplant, we also need regimes that allow us to maximize their quality of life, and some of these new agents can offer that as well. So thank you very much, and I'm very happy to take any questions.
Thank you, Austin. I think that's a really informative overview of what's available to these patients. And I think we have to take a step back and think about actually what a great position we're in compared to 10 years ago, where we had very few treatment options, and now we have all these. I am aware we've got 15 minutes left in this session, so I will do my presentation and I'll try and do it in like 10 minutes or so. But I just want, Austin, if you could answer one question that we've got in the chat, which is from Renata, like, how can we access ruxolitinib for secondary HLH? Do you know the answer to that?
Yeah, my understanding of this is that at present it is unlicensed, and in the current financial environment, you're going to have to try to persuade your trust to fund that. It is available, so you can get a hold of it, but you would need to go through your local DTC to get approval for it and then funding for it. There is, with JAK inhibitors, there is a slight cheat, which particularly if you have a proven genetic disorder, if you can prove an abnormal type 1 interferon RNA expression sequence on, so there are now some labs that have set this up as an RNA based assay to look at type 1 interferon expression and the genes that impacts. If you can demonstrate dysregulation on that, then it is available through blue tech form, and therefore it would be centrally funded. With some of the more obscure disorders, I think that's definitely worth looking for. However, for upfront, you are going to be reliant on trying to persuade your governance process within your trust.
Great, thank you so much. Even though we are a bit time pressed, I would still encourage people to think about some questions for Austin and Anu and pop them in the chat. And if we've got some time after my talk, I think it'd be great to be able to do that, because the audience is a little bit quiet today. Great. So Austin, if I can ask you to stop sharing your screen, and then I can, I'd like to give a brief presentation. Let me just come to this. A brief presentation, really just to take that step back and show how we can how we've moved on from the clinical trials that Austin's talked about to something a little bit more translational. So I'm going to talk about drug repurposing and XLP and ZARP deficiency, and talking about those two diseases in this forum, because these are both rare diseases that will present or can present with HLH, which can be a fatal complication of these diseases. Sorry, it's not letting me move on. Okay, so talking about XLP first, X-linked proliferative disease. So this is a severe monogenic primary immune deficiency, and it arises from mutations in the SH2D1A gene, which encodes the SAP protein, which is a SLAM-associated protein. And SAP expression SAP's expressed in T, NK, and NKT cells, and is fundamental in immune regulation and surveillance. So depending on the cell type and the receptor type, SAP binds to SLAM receptors intracellularly in these ITSM motifs and initiates a signal transduction pathway that's involved in modulation of immune responses. And that signaling pathway can be either a positive signal or a negative signal leading to activation or inhibition, again, dependent on the cell type that it's working in. But ultimately, SAP deficiency repairs in primarily impaired T cell responses. It does affect NK cell cytotoxicity and NKT cell development, but it's really the T cell compartment that it has the most profound impact on. So we see impaired cytotoxicity of cytotoxic T cells. We see impaired re-stimulation-induced cell death in CD8 cells, and also impaired germinal center responses in T follicular helper cell development and function in the CD4 T cell compartment. So currently patients are treated essentially according to the symptoms that they present with. So treating malignancy with chemotherapy protocols, treating HLH with some immune suppressive regimes that we've heard about. Patients who have abnormal T follicular helper cell function are on replacement immunoglobulin therapy to prevent against recurrent infections. But ultimately, stem cell transplantation is a curative option, and gene therapy approaches are in development. So a few years ago, this paper was published, which was really looking at checkpoint inhibitors for cancer. But what it showed was that SAP inhibits the function of SHP2, leading to an absence of phosphorylation of PD1 and proximal TCR signaling molecules such as CD28. And in the absence of SAP, you've got SHP2, overactivation and PD1 expression. So they were looking at this from the cancer point of view, but we were interested in it as a potential therapeutic for patients with XLP. So we wanted to know whether this could be clinically relevant, and we asked some kind of mechanistic research questions, but really what we were focusing on is, can this SHP2 inhibition rescue XLP patient T cell function in vitro? And can SHP2 inhibition rescue a murine model of SAP function in vivo? So one of the first things that we showed, and this was on patient cells, is that SHP2 inhibition could restore T follicular helper cell function. And we did this through a TFH functional assay where we co-culture CD4 cells, and this is 10 days post-culture of CD4 cells and patient cells, and we immunophenotype those cells afterwards and look at functional analysis, and we basically look at whether these cells in this co-culture assay can produce immunoglobulins, so IgG and IgM, and also IL-21, which is a cytokine pretty specific for the TFH population. And what you can see in all of these situations is in that compared to healthy donors, donors. XLP patients had very significantly reduced IgG, IgM, and IL-21 levels, but following addition of this SHP2 inhibitor, we could improve those responses almost back to basically healthy donor levels, particularly in the context of IgM and IL-21. So we'd shown that SHP2 inhibition could restore TFH function in patient cells. And then we wanted to know whether we could improve the CTL cytotoxic response of these patient cells. So again, we cultured these cells. This is a chromium release assay. We cultured these cells, patient cells and healthy donor cells with the SHP2 inhibitor and without it. And what you can see here is that these are patient cells without any SHP2 inhibition, and you can see that they barely have any killing. These are black lines are healthy donor cells, both with and without the SHP2 inhibitor. And you can see that patient cells treated with the inhibitor can normalize the cytotoxicity. And importantly, when the healthy donor cells, we don't see any adverse impact of the SHP2 inhibition on their function either. So that was very good. So re-stimulation-induced cell death is quite an unusual assay and thing to look at. And we took healthy donor cells and patient PBMCs. We activated the TCR, the T cell receptor, with the anti-CD3, CD28, and IL-2, which is a fairly standard way of activating T cells. We incubated them for 24 hours, and then we re-stimulated them with varying concentrations of a stimulant called OKT3. And then we looked by flow cytometry 7 days after re-stimulation using a PI stain, which basically looks at how many cells have died. And this is a bit of an unusual situation because normally when you re-stimulate cells, they die. That's their sort of protective mechanism. But what you can see here is that in XLP patients, they don't die because they're resistant to re-stimulation-induced cell death. And you can see that in this flow plot here. What importantly we saw was that in patient cells, when we added the SHP2 inhibitor, we get a really significant improvement in re-stimulation-induced cell death. So those more cells die appropriately. So we demonstrated that we could improve that phenotype as well with SHP2 inhibition. So that was the work that we'd done in vitro on patient cells, but we wanted an in vivo model. And we do have a SAP murine model that recapitulates fairly well the patient phenotype, particularly in the context of humoral immunity. So these animals, they don't get germinal center formation upon vaccination. And they have reduced IgG1, and that's what we were particularly looking at in these mice. So we gave them SHP2 inhibition, and then we vaccinated them with a T cell specific antigen NPCGG, and then we looked to see whether these animals with SHP2 inhibition had made an appropriate response or not. And again, what we were able to show is that inhibition of SHP2 did restore the T follicular helper cell population in SAP mice back to wild type levels upon vaccination. And we looked at that through flow cytometry, phenotyping the TFH cells. But we also looked at that, we looked at germinal cell formation, germinal center formation. And again, we were able to demonstrate that with SHP2 inhibitors, these mice could restore germinal centers. We did that through flow here, but also this is probably an easier way to look at it in splenic sections when they've been vaccinated. In the unvaccinated animals, both wild type and SAP, you don't see any this is germinal, you don't see any germinal center formation. On the vaccinated mice in the wild type, you can see these brown areas. These are staining for germinal center formation. Knockout mice aren't able to form these germinal centers, but this is the knockout mice who were vaccinated and treated with SHP2 inhibition, and you can see that they can form germinal centers just like the wild type mice. And that was borne out in terms of the IgG response as well. In these animals, we were able to demonstrate a restoration of IgG1 and antigen-specific IgG after these animals have been treated with SHP2 inhibitors and vaccinated. Just kind of looking at it from the other point of view around side effects, we didn't see any differences in the global white blood cell population post-inhibitor treatment. So it didn't affect other cell lines, and it didn't affect any T cell memory populations, either the CD4 or the CD8 compartment as well. So that just demonstrated that the effects were really targeted and specific. So just to summarize, in the treatment of patient cells, XLP patient cells with a SHP2 inhibitor, we could rescue the T follicular helper cell function, we could rescue a CD8 CTL cytotoxic function, and we could rescue re-stimulation-induced cell death. We could restore in vivo humoral immunity after SHP2 inhibition and challenge. And this really is data supporting the clinical use of a SHP2 inhibitor as a potential bridging therapy in patients. So we published this earlier this year, and we're able to use this as evidence to support compassionate use of this. It was actually initially Revolution Medicine who gave us the SHP2 inhibitor as part of their cancer program, but they've subsequently licensed that to Sanofi, who we're able to contact. And this was all the work of Neelam Panchal, who is a PhD student and postdoc in my lab. I was just going to briefly talk about ZIAP deficiency, and I don't have to do too much on the background because Austin's already introduced this, and also Rebecca Marsh presented this last year. But I really wanted just to highlight this because this was work that Histio UK funded, and I want to demonstrate what an impact that can have. So ZIAP deficiency is a rare inborn error of immunity, fairly recently described in 2006. And it's characterized by immune dysregulation, and these patients can have, over half of the patients will have HLH, which is often recurrent and quite resistant. They also get inflammatory bowel disease. And what I want to focus on is these patients have a worse outcome post-transplant than other types of familial HLH. So we really need alternative treatments for these patients, like biologics, and we're also exploring gene therapy. Many different manifestations are now being recognized outside of that sort of trio that was classic. We're seeing a lot of autoimmunity, hepatitis, uveitis, arthritis, skin abscesses, and then there's some non-classical manifestations as well, which are really, really extensive and being recognized as part of the ZIAP phenotype. This Austin's already talked about. It's ZIAP's just important in inflammasome control. And historically, these patients have had a poor outcome post-transplant, initially thought to be related to the heavier chemotherapy, myeloablative chemotherapy, and improving somewhat with reduced intensity conditioning. But we are now seeing successful transplants with more ablative conditioning. And what I wanted to also say is that actually, in some cases, we do see HLH in these patients post-transplant, despite high-level donor chimerism. So alternative management options for the HLH in these patients is still necessary. And we're still learning. I think Austin showed one of these graphs as well, but this was work from Rebecca Marsh earlier this year, showing that actually, these patients are acutely sensitive to graft versus host disease, and that can really significantly impact on their outcome. So we see that in patients who have no acute GVH, their survival is excellent, but acute GVH, even grade 1, can have a significant impact on survival. So here we can see even in grade 1 GVH, your survival's fallen by 10%, but even grade 2 GVH, your survival's down significantly. So Austin's already talked about this. Patients with ZIAP deficiency have increased levels of IL-18, which is activated by inflammasomes. And this work from a few years ago had demonstrated that even in ZIAP patients who were stable, their IL-18 levels were still raised. So it's a very good biomarker for this. So Rebecca Marsh had been looking at whether quercetin, which is a natural antioxidant, obviously present in elderberries and red onions at quite high level, and available to buy at Holland & Barrett, could be potentially used as a therapeutic measure. And this is already in trial for Fanconi anemia in the States for improving that. So this, as I said, it was funded by Histio UK, but Rebecca Marsh in Cincinnati and Neelam, who I've spoken about, looked at this research whether quercetin could ameliorate the hyperinflammation seen in ZIAP deficiency, and demonstrated that indeed it could. So this line up here is the murine work that Neelam did, looking at the inflammatory response, so IL-1 beta, IL-18, and TNF alpha in ZIAP knockout animals who have a really high levels of this in response to LPS stimulation. However, upon the addition of quercetin, you can see that their IL-1 beta, their IL-18, and their TNF levels significantly reduced, demonstrating control of that hyperinflammation. And similarly, looking in some ZIAP patient cells, again, IL-1 beta saw that with the addition of quercetin, you could really reduce that IL-1 beta and that inflammation. So again, this is something that will hopefully move forward to clinical trial for patients with ZIAP deficiency and hyperinflammation. So I think, we're learning, as we learn more about disease mechanisms, we can find more potential therapeutic targets, and drug repurposing is a really attractive option because it offers quite a rapid and often cost-effective option for diseases with unmet clinical needs. But also, I think, as Austin's also highlighted, undertaking clinical trials in rare disease is challenging just due to the patient numbers, and global collaboration is super important in this area. So I'll stop there, and I will, I think it'd be happy to take any questions from you, but also I think for Anu and Austin, just as we come in on time for the break before the adult session. So I can't see any new questions in the chat that relate to those particular presentations that we've had. And I'd just like to thank our speakers for sharing some fantastic presentations today that are highly relevant to the clinical care of pediatric patients with HLH.
Thank you very much, Claire, and thank you to all of your speakers this morning.
Okay, well, it's 2:30 by my clock, so I wonder if we'd be happy to kick off the second half of the meeting, and that will mean that the background slide can come down, and hopefully Betty Gratian, who's our first speaker, will be able to share her screen. So I'm Rachel Tattersall. I'm an adolescent rheumatologist in Sheffield, and I'm co-chairing this session with the co-chair of my of the HIHASC, Hyperinflammation and HLH Cross Specialty Network, and we're very kindly hosted by Histiocytosis UK, and it's great to see such a wide national and international attendance at this meeting. The first part of this afternoon is abstracts, which have been submitted and reviewed for presentation, and then some talks culminating with a keynote from Grant Schulet to close out. So our first speaker is Betty Gratian. She's an academic clinical fellow and haematology registrar at University College London at the moment. She's working on CAR T-cell therapies for and as part of the team there. And she's got a very interesting background. When you ask people for their biographies, you get an amazing background. I haven't got time to read out everything here, but I'm really looking forward to welcoming Betty to talk to us about the experience of primary HLH in adult patients. Thanks, Betty. I'll hand over.
So my presentation is on primary HLH in adults and talking about the prevalence, genetic testing and the use of ruxolitinib, which we've heard a little bit about already, which was much more than I'm probably going to give you in this presentation, but anyway. So there we go. So primary HLH is widely reported to be a diagnosis primarily of childhood. And through this, we often find it very difficult to justify the cost of highly expensive and specialised genetic testing outside the paediatric setting. However, my presentation is going to present 3 cases within the past 2 years at UCLH, where we have had significant findings on genetic testing and raised the possibility that this is actually a self-perpetuating position that we're in, where we don't look for something and therefore don't find it. So the cases that I'm going to present to you are, there are 3 patients, the first of which was a 22-year-old male. He had a background of consanguineous parents and had had recurrent infections, including atypical infections such as aspergillus and various other fungal infections. He was, as I'll come into more details later, but he was diagnosed to have a perforin gene mutation. This diagnosis was made in a quite timely fashion, such that from his presentation to treatment, well, definitive treatment with an allograft, was just within 4 months. He's now well. Well, I say well, but I mean, all allograft patients have got their own complications, but in terms of his HLH, that's now completely treated and he has had his definitive treatment. The second patient, unfortunately, wasn't quite as simple as that. So this was a 28-year-old female who presented with similar well, all of them presented in a similar way, which we'll come on to. She also had consanguineous parents and a background of autosomal recessive limb girdle muscular dystrophy type 2, which in hindsight turns out it possibly was actually all part of her Grossetti type 2 syndrome. In terms of her clinical features, she had a short stature and grey hair that was significant considering her age, all of which were things that as adult physicians we didn't really take into account because we don't see these patients so often. She was diagnosed with Griscelli type 2 syndrome after 6 months after diagnosis. She's currently doing pretty well, actually, given how close she came to, she faced death many, many times, much of which is due to ruxolitinib. She's awaiting an allograft, which will hopefully be in the next couple of months. My final case to present is of a 67-year-old lady. So she had a background, well, she actually didn't have any family members that we could contact, and it was a reasonably sad case. She lived on her own, so we don't really know much about her family history. She had moderate learning disabilities, and she also had congenital telophase equinovarus. Apologies if I've said that wrong. Her genetic results came back with an NLRP3 gene mutation, which, unlike the other two, which are, diagnostic of primary HLH, this is of an undetermined significance. And I guess as a condition that we're learning more about all the time, particularly from conferences such as this, we will hopefully have better understanding in the future. Her outcome, unfortunately, was that she passed away, and she actually passed away before we got the results of this mutation. So in terms of the diagnostic features of them, apologies for my awful pictures here, but I just wanted you to keep in mind who they are. And the slightly smaller version here is so that you know that she was shorter. Anyway, so they met all the criteria, well, pretty much all the criteria. And as you can see, the ferritin levels of them were really quite significant. So when you've got patients that you're questioning whether or not they've got HLH with a borderline ferritin, I think this really shows how high they can go. The bone marrows of them, I think, is actually quite interesting to see, because obviously a bone marrow is a really invasive procedure, and on a couple of our patients, 4 bone marrows is a lot to put a 67-year-old lady, particularly in her situation when she's got learning difficulties and couldn't really fully understand why we were doing it, and none of them really gave us a proper answer. So with the first patient, the 22-year-old male, we got reactive bone marrows on both of them. With the second patient, we never found hemophagocytosis, but there was increased T cells, which to this day I don't know the complete significance of, but it probably actually confused us. And then with the 67-year-old lady, there were lots of different, all 4 of them were poor samples, and they came up with lots of different things on flow cytometry, and really probably led us down unhelpful directions. So starting with the first case, so he presented in February with pancytopenia and chest sepsis. I'm not going to go through all of these, but just to show you the extent to which we investigate these patients, and which is first a cost to the NHS and also a significant impact on the patient when they're going through all of these investigations and we still don't know the cause. They seem to sort of I would certainly seem to lose faith in us as medical professionals. The complications that he encountered, so he had to be NG fed for abdominal pain and also just being deconditioned whilst he was there. Sorry, I put that twice. He was admitted to ITU, I think it was 3 times, mainly due to sepsis. He had retinal hemorrhages, which I'm sure is related to the hypofibrinogenemia. He became significantly deconditioned, and he had multiple fungal chest infections. I'm sure that a lot of this will be secondary to the condition itself, but also the immunosuppressive agents that we're using. In terms of HLH management, we used anakinra, steroids, in dexamethasone and prednisolone, and etoposide in him. His formal diagnosis was made in June 2020, which is just 4 months after presentation, which is pretty impressive. And I think that a lot of this was sped up by the fact that he had an absent perforin expression, which is, one of the first tests that we do. And if that is abnormal, then it sort of increases that it makes it much more significant that this is going to be a primary cause, and therefore makes it easier to justify going further with NGS, which he had in June, and he was found to be homozygous for a pathogenic variant in the perforin gene mutation. And in terms of this other mutation that's found here, I just want you to be aware of the fact that there was another mutation found, and I'll talk about that later on. His outcome is fantastic. Within 2 months of this diagnosis, underwent an allograft, and he is now reasonably well. The second case, she presented in December 21 with fever and rigors. I didn't realise there was all these animations, sorry. She had multiple investigations, again, just showing you the extent to which we put these patients through investigations and also cost the NHS. Her complications were that she had significant hyperalbuminemia, her electrolytes were persistently low, she had to be NG fed, she had multiple hospital and line associated infections, she had liver toxicity with an ALP going above 4,000, which is most likely due to be secondary to iatrogenic causes, because we went down various alleyways and ended up treating her empirically for TB. She had to be admitted to ITU twice. She had this empirical TB treatment because we couldn't really find any other cause, and she had a significant exposure and thickening on her abdominal wall, which ended up being probably unnecessary, but at the time we had nothing else. And in this case, she really did become very depressed. She was isolated. She had a very young daughter who I think she was under 1 year old that she was unable to see. And she really did seem to lose faith in what we were doing and started to refuse lots of investigations that we as medics couldn't understand. But in retrospect, I can understand how she felt in that position. Her treatments included IVIG, which she had on 3 occasions, anakinra, cyclosporin, etoposide, multiple steroids, and eventually ruxolitinib, which I'll come on to in a moment, and really was the saving grace for her because it allowed her to be fit enough to get through to go to allograft. So her diagnostics, of note here, she had an abnormal cytotoxic granule release assay in January, which is very soon after that's only a month and a half after she presented, but it had to be repeated before going through to NGS because it's got very low specificity, so particularly in cases where patients are very unwell. She did have normal perforin expression, but of course that abnormal perforin expression is only seen in a third of cases of primary HLH. Her soluble CD25 was above 20,000, which is very significant. And eventually, when we did get her genetics, she was found to be homozygous for a mutation which represents Griscelli type 2 syndrome. Again, as I asked you earlier on, to just hold in mind the fact that there was a second mutation that was found, which in her was the BRCA2 mutation. So when we got this diagnosis, she was actually very, very unwell. And it kind of happened around the same time that we managed to get compassionate access to ruxolitinib. So she is currently no longer admitted. She's an outpatient and she's pretty stable on ruxolitinib and cyclosporin and awaiting an allograft. The third case, this was the 67-year-old lady. She again went under lots of different investigations, had multiple complications, and she was treated with anakinra, etoposide, steroids, and cyclosporin. She also was treated with 1 dose of tocilizumab, which was, it was questioned whether or not she might have stills. I think that nobody really believed that, but we were sort of, at a loss. There was no diagnosis at that time, and she was pretty dependent on etoposide, and every time we started to wean that, she would go off again. We did, well, I didn't, but ruxolitinib was tried to be accessed again on a compassionate access scheme, And this patient was later than the previous patient and unfortunately was declined. Her results were done much later, and I guess that makes sense given she's a 67-year-old lady. If this is a diagnosis only of childhood, then you're not going to believe that it's going to be the case in a 67-year-old. She had a normal cytotoxic granule release assay, normal perforin expression, soluble CD25 was significantly raised, and we found this mutation, which is undetermined significance at the moment. Unfortunately, she died before we got this mutation diagnosis. So the learning points I'd like to bring here, I mean, there's so many of them, I could talk for hours. First of all is recognizing clinical features. So as adult clinicians, we don't know these conditions, and we all had to Google Grasselli type 2 syndrome and didn't necessarily recognize the features in her being short with grey hair. Consanguineous parents is also pretty significant, and that should raise our suspicion. The delay to NGS, so if we have high clinical suspicion, then perhaps we should be doing it earlier. Repeating tests as well, that caused a significant delay in the second patient I talked about. And also recognizing the iatrogenic damage that we're doing with these patients and trying to have more of a holistic approach. So they're very isolated, they've got multiple tests going on, and whether or not we can optimize their treatment to make sure that they have some form of quality of life. I'd like to then talk briefly about ruxolitinib. I don't know how long I've been going on for, apologies. So ruxolitinib was absolutely fantastic.
You've got about 1 more minute.
Okay, fantastic. So ruxolitinib is a protein kinase inhibitor that I won't go into details of because we've already heard about it. In this patient, we got it as a compassionate access scheme from Nevada, and unfortunately weren't able to get it again. She was saved through this because this has allowed her to go from a state where she was, there was no way she would have survived a transplant, and now she is fit and she's able to be at home with her daughter. There was an immediate reduction in her fevers, her ferritin, her LFTs, and this periorbital edema that I didn't go into detail earlier, but meant that she could not see at all, were dramatically reduced. So considering this agent and other agents and in other centres, if you're able to apply and, it may be helpful there as well. There is data out there. A lot of it is in animal models. There is one paper from 2022 that talks about its use in paediatric cases. But it is important that we try and look at more cytotoxic sparing therapies. Finally, I just want to very quickly say about the service changes that have come about through these cases at UCLH. So now all patients with HLH are having their immunology done, and this is basically to try and identify what the actual prevalence is out there. There is a database that's looking at pattern recognition so that we can try and see things earlier on in these patients, such as, oh, they've got grey hair, that means we should think about blah, 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 etc. Reducing delays, so when a patient is very sick, we no longer have to wait for a second confirmatory cytotoxic granule release assay, and we can go straight to genetics. MDTs are very important everywhere. We have 2 MDTs at UCLH. One is for mainly for referrals, and we're coming up with new ways in which we can get more information from the outside hospitals in terms of what tests have been done, so things can be sped up. And then the internal MDT is also very useful because it's cross-specialty, so you get different opinions from everywhere, which, as everyone knows, is particularly important in HLH. And finally, novel treatments to minimise cytotoxicity. I've talked about the compassionate access schemes, and there are also clinical trials going on, such as currently there is the clinical trial for a SERP1 inhibitor, SERP1 directed monoclonal antibody, which hopefully will be of use. And finally, I just want to say thank you very much to Jess Manson and Sat Gohill, who lead the HLH service and have been very inspiring, as well as Histio UK for giving me this opportunity, and most importantly, our patients, because with these conditions, we are learning a lot from them, and hopefully being able to provide better for future cases. Thank you.
That's great. Thank you, Betty. I can't see any questions in the chat. I would just signpost that Joe West, our colleague, did put about the his recent publication about the incidence of HLH and the expected incidence in children in the UK. I guess that's a whole nother scenario further on. If you can put questions in the chat, we'll probably group them all together and put them at the end of and answer them at the end of the abstract session, if that's okay. So thank you very much, Betty. I'd like now to welcome Dr. Khan, Harris Khan. He's currently doing a second year of internal medicine training at Frimley Park Hospital in Surrey and is doing haematology currently. If you'd like to share your screen, Dr. Khan, that'd be great.
Thank you for having me and for this opportunity. Can everyone hear me?
We absolutely can. And I should, of course, have done you the courtesy of reminding everybody what you're talking about. So the title that you're talking about is When It's Not Just Typhoid Fever. I'll let you go.
Absolutely. Can everyone see my slides?
I can't just yet.
Yep, we can now.
Great. Okay. Right. So as mentioned, my talk is on when it's not just typhoid fever. So essentially, we had a previously healthy 23-year-old man who had recently returned from Pakistan, Karachi, and he presented to us in Frimley Park Hospital with 7 days of fevers, diarrhea, vomiting, and abdominal pain after eating some spoiled burfi, which is essentially a traditional confectionery which is usually sold in South Asian countries. So initially he'd gone to a tertiary centre with symptoms of diarrhea, but no other symptoms at the time. And they'd taken some blood cultures and reassured him and just advised him to come back if things had worsened, which unfortunately happened in the next few days, as well as developing these other symptoms as well. His family had also been on the trip with him. And at the time that he developed the symptoms, they had no symptoms. However, a few weeks earlier, they had mild kind of gastrointestinal symptoms. And this is burfi. If someone doesn't know what that is the dessert that he had. Usually it's quite a tasty dessert. Unfortunately, in his case, it was a spoiled batch and his family made the sensible decision not to eat it as well. So in terms of investigation, blood cultures initially grew Salmonella typhi. And the tertiary centre he went to, they also said that they had concurrent blood results. And he had stool cultures as well, which also grew Salmonella. So he was initially treated with ceftriaxone and gentamicin as per the sensitivities. However, a few days later, there was no clinical improvement. He was still having temperatures. So we rediscussed with the microbiology team, and they advised to start meropenem and azithromycin, as they thought this could be a resistant form of Salmonella, which is quite common in South Asia and the Middle East. His condition, unfortunately, continued to worsen, and he had to go to intensive care for IV electrolyte replacement because he had quite a significant hyperkalemia, hypermagnesemia, and hyperphosphatemia, and he also had ECG changes at the time. So within kind of 5 to 6 days of his admission, he had multiple lots of antibiotics and treatment. He was still spiking high temperatures over 39 degrees Celsius, developed thrombocytopenia, his platelets went down to 34. He had a good going transaminitis and coagulation disturbances, and his ferritin went quite high, up to 32,000. However, from the presentation before, I could see a ferritin of 500,000 as well, so clearly not as high as it could be, but fairly high still. And also, in addition to this, he developed a new murmur as well, but he had no other kind of significant examination findings. There was no obvious rashes, organomegaly, or any kind of lymphadenopathy that we could identify. So because of his deranged liver function test and his new murmur, we did an ultrasound abdomen and an echocardiogram, both of which were normal. And then subsequently, he had a CT abdomen and pelvis, which just showed kind of small lymph nodes and minor fat stranding, which was ingoing with typhoid fever. By this time, we were all quite scratching our heads because we weren't too sure what was going on. The rheumatology team were involved, microbiology, hematology were all involved. And there was kind of a ward MDT as to what the next kind of steps and guidelines were. And as I said earlier, as there had been no clinical improvement despite various antibiotics, he'd shown a drop in cell counts, his liver function tests were deranged, his triglycerides had gone up to about 5, his ferritin had gone up to 32,000, and his fibrinogen had dropped to 1.2. So with this kind of ward MDT, we all suspected a secondary HLH, and his initial H score was about 196. Fortunately, we had the luxury of the UCL HLH MDT and the experts there as well, and they advised us on treatment as well as sending a HLH genetic screen to the Great Ormond Street Hospital, the results of which are still pending at the moment. However, he had a bone marrow biopsy which did confirm hemophagocytosis, and his H score as a result went up to 231, which increased the probability of him having HLH to 98 to 99% essentially. I don't know if these bloods are very clear, but as you can see, his these are about 4 or 5 days after he came in. His potassium had dropped to 2.5, which improved with some kind of IV treatment. His LFTs, as you can see, his ALT has gone up to 635, and his AST was 887. It's a significant drop in his phosphate to 0.29. His triglycerides 4.4, which earlier they were even higher than this. And he had a mild drop in hemoglobin, and platelets were quite significantly dropped. As you can see, his ferritin, as we mentioned earlier, had gone up to 32,000. There was a derangement in his clotting profile, and his fibrinogen had dropped as well. And this is his HS score, which he scored for as the high temperatures he was having for his one lineage cytopenia, his ferritin being high, his triglycerides, and his fibrinogen. Also, his AST, as we said, was quite high, and the bone marrow also confirmed the hemophagocytosis. Now, treatment-wise, he was given pulsed IV methylprednisolone, 1 gram a day for 5 days, and in addition, he was given 2 doses of IVIG, 1 gram per kilo. And this kind of remarkably showed a great improvement in his clinical conditions. His fever stopped after 24 hours. He felt much better in himself. His cell counts continued to improve and improve significantly. And the patient made a very good recovery. And he was discharged home with a tapering dose of steroids and followed up with rheumatology as an outpatient. So after he was discharged, he was very keen to go to South America, despite our kind of advice. And we kind of just said that the best possible course of action is to avoid the typhoid vaccine when you go to South America, because that could cause the HLH to occur as well. And these are his bloods after treatment. So as you can see, pretty much all have normalized. His ALT is very, very mildly deranged, but significant improvement in all of his bloods. And this is the guidelines, which I'm sure many of you are very familiar with in terms of we used the UCL protocol, which was essentially giving him IV steroids initially alongside IVIG. And if that hadn't worked, we would have gone for the second line treatment, which was anakinra. And had that not worked, we would have gone for third line treatment, which is topside, as mentioned earlier as well. And parallel to this, obviously we need to kind of identify the cause for him developing this HLH, when his case was the salmonella, and he had the appropriate kind of antimicrobial therapy for that. A little bit about salmonella. So salmonella essentially is a gram-negative bacilli, and it belongs to the Enterobacillus family, and it's one of the main causes of enteric fever. It's usually transmitted via the fecal oral routes, and can also be transmitted through poor food and water hygiene and through infected individuals and contact with them. It's quite common in Southeast Asia and parts of Africa and the Middle East. And in Pakistan and Iraq, there's an extensively drug-resistant typhoid, which is commonly seen and which is also apparent in our patient, where these patients are resistant to numerous antibiotics such as amoxicillin, cotrimoxazole, chloramphenicol, fluoroquinolones, and some cephalosporins as well. And our patient was resistant to quite a few of these as well. Now, in terms of literature on salmonella and HLH, it's a rare phenomenon where HLH is caused due to salmonella. However, it's not completely unheard of. We found 2 case reports online which reported this phenomena. The first was Iribi and Londoner reported a case report in Colombia where there was an 8-year-old girl who developed HLH secondary to salmonella, and she recovered very well with antibiotics and IVIG. And similarly, another case report by Abbas et al., which was coincidentally also in Karachi, where a 4-year-old girl who developed HLH secondary to typhoid as well. And she was treated with antibiotics and platelets and red cells, and she improved significantly as well after 2 weeks. So fortunately, in all of these cases, our patients had very good outcomes. And I believe that's due to early kind of recognition, appropriate antibiotics, and recognition of HLH and early therapy for that. A few learning points that we had. The first thing is just kind of always step back and consider ongoing pathology. Sometimes you have patients who don't fit a certain diagnosis, and there's certain trends that are slightly odd. So just to always consider other things and to get other specialist input as well to optimize patient therapies. Secondly, the importance of prompt microbiological investigations prior to antibiotics, stool cultures, blood cultures, again, very helpful in eradicating the patients and whatever kind of microorganisms they may be affected by. One kind of thing that was very, very useful was the MDT between the departments and the specialties we had in hospital, and also with UCL, because this allowed everyone to kind of have the right guidance and treatment options available, which allowed our patient to have a great recovery. And one question that we all discussed was, and I'm sure some of the experts will be able to answer this, is in terms of the HLH developing, is it the prolonged bacteremia, or if the antibiotics are started in straight away and is identified straight away, can that maybe prevent the development of HLH, or is something which is linked to some other factors possibly? And lastly, to never forget to think of HLH in patients with ongoing fevers which are not responding to antibiotics and other therapies. And these are just some of the references for the case reports that we found in relation to salmonella and HLH. And is there any questions?
I can't see any in the chat, Dr. Khan. That was really fantastic presentation. Thank you very much. There's a bit of a theme developing about MDT working, isn't there? Multidisciplinary team working. And I think we'll be continuing that. We'll perhaps let people think about questions. I'll ask Dr. Thomas Nadin to present next, and then we could come back if you'd like to put your questions in the chat. Put your questions in the question and answer box at the bottom of your Zoom screen. We'd be really happy to take questions if that's helpful. So Harris, if you can stop sharing your screen, that would be great.
Thank you for this opportunity.
Thank you very much for coming. I'd like to introduce Tom Nadin, who's in his first year of specialty rheumatology training in my team in Sheffield. He's put together on the MDT theme an abstract presentation relating to an evaluation of the real work of an MDT over 5 years. And I'll hand over to Tom. Hopefully you can share your screen. You've got about 10 minutes, Tom, and then we'll move to questions. Thank you very much.
Can you hear me okay?
I can hear you beautifully.
Great. Okay. So I'm just going to share my screen now. And can you see my slides okay?
Fantastic, Tom. Go ahead.
Great. All right. So hi, everyone. I'm going to give a talk today on our experience in Sheffield over sort of the last 5 years or so on HLH, and that's at Sheffield Teaching Hospitals. And I should give credit to Beth Ordas, a very enthusiastic medical student who was responsible for the bulk of the work that I'm presenting today, and was supervised by Dr. Tattersall in the work that were completed. So the first slide I'm not really going to spend any time on. We've all heard today about the mechanisms of HLH and the cytokine storm, etc., and how significant the disease can be, including some of the triggers. So just to give some context, in Sheffield we have a multidisciplinary HLH group, and I'm going to abbreviate that to MDAG for the talk today. And the point of this is of the group is to advise on care for patients with or suspected of having HLH. And there are a variety of specialties, including rheumatology, ITU, hematology, infectious diseases, and virology. And the group meets either face-to-face or virtually has been much more common over the recent years, with referrals going to a central email address, the HLH, the MDAG. And the outcome of discussions about patients will be uploaded then to patient records, electronic patient records, which is what EPR stands for. Prior to the COVID pandemic, there'd be meetings every couple of months with reflection, and from that, a local guideline for HLH was agreed. So the aim of our study was to describe the causes and outcomes for patients with HLH in Sheffield between October 2016 and September 2021. So patients included were those with HLH who referred to the MDAG between those dates, and data from their electronic and paper records were analysed using Excel. The outcomes we looked at were age, gender, cause of HLH, mortality, treatments including steroids and anakinra, the need for critical care, and length of stay for patients who did survive. We looked at the data overall, but also pre and post March 2020 to reflect the COVID pandemic, of which it did produce some interesting results. To begin with, I'll look at the results table here. So some demographics, you'll see the average age was a mean of 52 years overall, with not much difference pre and post pandemic. There were 35% of patients who were female, which is more common in males, which is as you'd expect with HLH. And there was a difference again in the proportions of males and females, slightly, with more males being affected after the onset of the COVID pandemic. Mortality was around 53%, so very high, with it being significantly higher, around 72%, and dropping quite dramatically to 31% if we look at that time frame of pre and post COVID pandemic. The need for critical care again is very high. There were more patients who went to critical care beyond March 2020. Perhaps that would be due to an earlier recognition of HLH and patients being escalated is one possible explanation. And then if we look at the length of stay, so this is for patients who did survive to discharge, very similar across the board. Around 9 in 10 patients were treated with steroids. Looking at and that would be dexamethasone or prednisolone, and anakinra was used in about half of patients, with a slightly higher percentage being used when COVID hit in March 2020 and thereafter. Okay, so just to go on to a few bar charts. So this is the overall cause of HLH in our study sample, which was a sample size of 79. The overwhelming cause was infection at 44% of those cases, closely followed by hematological, rheumatological, and other causes. So when I say hematological, these are all hematological malignancies. Rheumatological causes included, in the main, Still's disease, but also lupus, rheumatoid arthritis, and there was a patient with J1 myositis as well. And the other group, there were 3 patients who we weren't able to get a cause for. There was one with medication related, which was attributed to alemtuzumab, a combined case of sickle cell and JIA, and a primary HLH. So looking at that same spread of conditions, but prior to March 2020, so before COVID, we can actually see the predominant cause here was hematological in our cases that we observed. The second then followed by infection, that's combined bacterial and viral, and rheumatological causes and other causes again represented a fairly similar overall percentage of cases. If we then switch to after the onset of COVID, as you would well expect, to a big increase in cases related to infection, a relative reduction in hematological related cases down to just 22%. And again, pretty similar, small contributions, but still there of rheumatological and other causes. So just to look at the infection more specifically, and just to spell out clearly the effect that COVID had on cases of HLH, if we look at to the left where there's an overall section, this is number of infection-related cases, or the percentage of overall HLH prior to March 2020 compared to post. So we're looking at just under a third to then 2/3 after the onset of COVID. Bacterial, there's a similar kind of percentage. It has gone down slightly following the onset of COVID. We can see the number of cases, so 42% of overall HLH cases after March 2020 were directly related to COVID. And then other viral causes, which in the main were EBV related. Now moving on to look at mortality. So this chart here looks at mortality by cause. So hematological carrying the worst prognosis at a high 82% of patients not surviving. Other causes, so that would include the primary HLH, medication related, and there were some cases that we couldn't get a grasp of the cause. I weren't able to find that, so that was just under 2/3. Infection related actually carried a better prognosis at around a third of cases, and the sort of most in keeping with survival was rheumatological triggers for HLH. So just to discuss in our sample of patients here, that mortality and critical care need is high for HLH, and hematological malignancy carried the worst prognosis, which is described in other studies, as I'll go on to. That overall, the most common were infection, hematological malignancy, and rheumatological disease in terms of causes, and the others, as I've mentioned, primary HLH and alemtuzumab, medication related, for example. Prior to the pandemic, the most common in our study showed that malignancy, and in particular hematological malignancy, was the most common trigger of HLH, and after that it became infection. In terms of the treatment with anakinra, availability has been made. There's been an agreement locally for COVID HLH to be for patients to be allowed access to anakinra. That was around May 2020, so it might reflect the increased use of anakinra that was seen in the results earlier on. And the overall availability did change, so we were able to access it between 2016 and 2020, but it was more difficult on a sort of case-by-case basis, and we will see, I'm sure, some changes from October 2021 when we look at the data going forward from there, as the national commissioning did enable access to anakinra for HLH treatment. So we could see that mortality significantly dropped, as I mentioned before, from 72 to 31% after the onset of COVID. A few speculative reasons for this. So linkage with the UCL hospital and an MDT, given a more standardized approach, would have been of benefit. Better recognition of HLH during the COVID-19 pandemic, possibly then leading to earlier escalation of patients, for example. The locally agreed access to anakinra, facilitating faster treatments. And there was a relative reduction in cases related to hematological malignancy, given the rise in infection, but also possibly some due to the upskilling of hematology colleagues who may manage HLH cases, who responded well to initial treatments, managing them themselves and not being brought through the MDAG. Just to compare to a couple of studies, I hope I'm doing okay for time. So in 2020, there was a HLH German registry, 137 patients, and it reflected similar findings to ourselves, that the most common triggers would be infection and malignancy, although interestingly, infection was the most common cause prior to the COVID pandemic, which was different to our study, and other lesser contributions, but definitely there with autoimmune, rheumatological causes and idiopathic, which did include primary HLH. There was one case of testicular cancer, And from the survival analysis that was conducted, it looked like the survival, the mortality was around 2/3 for malignancy-related HLH. And then finally, a study by West et al. In 2022, this looked at incidence and survival of HLH across 16 years and found 214 patients, finding that survival varied according to age, and this was statistically significant, 77% in those less than 15 and only 30% over 75, which age alone, I suppose it could be a factor, but perhaps also the chances of being malignancy related could also be relevant. And they found that the hazard ratio, a significant one at 2.6, was found for patients who had malignancy related HLH versus no malignancy or rheumatological disease triggering their HLH. So just to conclude, in Sheffield Teaching Hospitals, the causes of HLH and overall mortality similar to that observed in other literature, with haematological malignancy associated disease carrying the worst prognosis. There was a significantly reduced mortality following COVID-19 onset, reflecting better recognition of HLH, the MDAG advisory group, and earlier access to treatment. There were no cases in our study group which were related to solid organ malignancies. There's no oncology representation in the multidisciplinary group, and perhaps some patients are being missed in this area, so that's something that needs to be considered. And as we've all mentioned today, further research and MDT working very important in moving care forwards and managing patients with HLH. And then just a couple of references there that I alluded to. That's all I had to say. Thank you.
Thanks, Tom. I think your slides have frozen, actually. The wonderful NHS Wi-Fi. We just missed your last couple of slides. I don't know if that's just me or if that's everybody, but you spoke to them beautifully. I'll hand over to Jessica just in case there are any questions.
So there are quite a few questions, but we don't have very many minutes. So co-chair, can I have 5 minutes, do you think, for questions? Do you think we'll be able to make those up?
Yeah, I think that's very reasonable.
Okay, so the first question for Betty, please, is whether you think that really all adults should be checked for primary HLH kind of as they hit the front door, or how do you think we should do this in a sensible way? If you can hear me, Betty.
Yes, so I think that well, with the three patients that I presented earlier on, all of them brought up results that we don't really know how to deal with. With the second female patient, she had the BRCA2 mutation. With the first patient, he also had a heterozygous mutation of undetermined significance. And the third patient, we don't really know what her mutation meant. So I think that testing everybody is actually just going to bring about more problems, and we should never be doing that screening in patients if there's not an increased suspicion. So I think that it's more about trying to understand the prevalence of this condition and making sure that we're not ignoring patients if it actually is prevalent in adults, and then coming up with sort of like a stratified way of dealing with these patients. So, if they've got other congenital conditions, if they've got consanguineous parents, then that increases your suspicion, and trying to bring that earlier on. And basically just not ignoring it in total. But yes, definitely not for everybody. It's very expensive, very specialised.
The consanguinity is such a paediatric question, and just not an adult medicine practice question, I think, which is one of the beauties of having the likes of Rachel in our MDT to sort of raise those sorts of clinical questions for us and make it part of our practice. So thank you very much. Harris, could I ask you a question from the chat, please? So this is from Ethan Sen, who's a paediatric rheumatologist, who was asking about kind of what led you to think about checking ferritin and thinking about HLH in your patients. And then second question, well, let me answer that one first, and then I'll ask you the second one.
All right. Okay. So I think what happened was that there was multiple kind of derangements in the bloods that we weren't too sure about what was going on. So as we said, because it was a ward MDT and the rheumatologists were involved, hematology were involved, microbiology were involved, so everyone was giving their input. So I think in the midst of it, because someone must have suggested the idea that, oh, let's check ferritin, because as you guys know, it's an acute phase reactant as well. So inflammatory responses tends to go up, and things like Still's disease and HLH, ferritin's significantly elevated. So I think it was just the multiple derangements in bloods, and someone must have, I think it must have been rheumatology who recognized this trend. Who said that it could be HLA. So I think that's why we sent the ferritin.
Okay, brilliant. And then do you think it will change your practice? Do you think you're allowed a ferritin on every unwell patient, and should we be? You can't say no, because Rachel's shaking her head like a crazy lady saying, I mean, nodding, sorry. So certainly, our approach is now to kind of add a ferritin to everyone who's unwell with fever when we don't understand what's going on. And I think that's
Absolutely.
probably in general medical practice where that will change.
Absolutely.
Thank you very much. And if I could ask a question to Thomas in my last minute and a half. So Thomas, in terms of the question about the hematological malignancies, the hematological diagnoses, what were the spread, and do certain heme malignancies do kind of worse than others?
Thank you. That is a very good question. I don't actually have the numbers straight to hand, but there was a spread of conditions, and we didn't look into whether specific ones lended to a worse prognosis versus another. But it's a good question. So
can I ask you a follow up then? And do you know what kind of infections there were? That was the one.
Infections. So the majority were viral. Clearly, the COVID, EBV. There was a case of HIV as well. So there were some other kind of other viral causes, but they tended to be in smaller numbers. The majority came from COVID and EBV.
Brilliant. And then thanks very much, Thomas. Just one comment from my colleague at UCLH, Vanessa Morris, about how kind of important these MDTs are, but how we need the NHS and the government to fund us all to do this work in an organised way, which I think is really, really important. Thank you, everybody, for an excellent abstract session. Can I hand back to Rachel?
Thanks. And can I just add that Bethany Ordas, the aforementioned medical student who did most of that work, has put in the chat that she did a breakdown of hematological malignancies, and AML, acute myeloid leukemia, caused the majority of the cases. But I've suggested to Renata that she emails offline if she'd like more detail. I'd be very keen to say that evaluation was obviously of a real world. I think it's difficult to give any causative. It was just to say it's. And
I think if your hospital is a lymphoma specialist hospital, you'll see lots in lymphoma. If you've got a particular AML person, you'll see it more in. I think that reflects the different practice of our trusts as much as I'm not sure. Exactly that. You said it better than me. Right. I'm handing back to you, Rach.
Thanks very much. So the next person I'd like to introduce is Dr. Miriam Cox. I have an apology to make to Miriam, who's one of our rheumatology trainees, in that we gave two speculative titles for this session and ended up putting the wrong one on the programme. So I'm really apologetic for that, but it probably fits better what you are actually going to talk about. So Miriam's a rheumatology trainee in Sheffield, but a very active member of High HASC, and has taken on the mantle of doing a survey across the UK looking at HLH MDT provision under the banner of High HASC. So she's not talking about our guideline for investigation. We're hoping that will be published very shortly, but she is going to talk about HLH services in the UK. So thank you, Miriam, and sorry for attributing the wrong title. Do you want to share your screen and see if we can get the technology going? And we can. Beautiful.
Perfect. So does that look like it's working now?
Looks perfect.
Perfect. So as Dr. Tattersall said, I'm going to talk a little bit this afternoon about some work that I've been doing looking at the current provision of HLH MDT services across the UK. And I think it's a theme that's come up in most of the talks that we've had this afternoon as well. So to start with, I'm sure everyone's aware from the talks that we've had already that obviously HLH is a rare condition, but it is potentially life-threatening, and therefore early recognition and early treatment are key to improved survival. The relative rarity of HLH, however, means that there is a variation in expertise across the UK and potentially this might lead to inequalities in access to care for patients presenting with HLH. Therefore, an MDT approach is key to ensuring that patients across the UK do get timely access to HLH treatment as needed. Therefore, the aims of this work that I've been doing have been to gauge the current state of play of HLH services in the UK, with a broader aim of hopefully then being able to improve MDT access going forwards. I know that some of these studies have been mentioned already. As Tom said, there's been a recent study out of Nottingham and by West that shows that there's been a fourfold increase in the incidence of HLH in the UK over the last 15 years. So the incidence has risen from 1 per million of the population to 4 per million of the population. And part of this, it's hypothesised, is due to the increased incidence of haematological malignancies, but also immunotherapies such as CAR-T therapy. And therefore, it stands to reason that as these therapies become more widely available across the UK, clinicians across the UK are more likely to encounter cases of HLH as part of their everyday practice. There's only one study that I could identify that looked specifically at HLH MDT provision. This was a paediatric study out of Boston in the US, and that showed that the introduction of a structured HLH MDT reduced mortality of HLH from 50% to 6% over a 3-year study period. The authors do acknowledge that there's confounding variables at play here, such as improved recognition of HLH and improved access to treatment that they couldn't adjust for. But nevertheless, I think it does add weight to the argument that MDTs do have a vital role to play in the timely management of HLH. Moving across to the UK, in 2021, NHS England released their clinical commissioning policy for the use of anakinra in HLH. And this policy does specifically mention that MDT discussions should be had prior to treatment with anakinra because of the relative rarity of HLH. So moving on to the work that I've been doing, I have been trying to gauge the current MDT provision for HLH across the UK, and I've done this via an online survey on SurveyMonkey that I've tried to disseminate as widely as possible across the United Kingdom. So primarily this has been using existing networks such as emailing the HIHASC membership, but we have also contacted individual contacts and individual hospital trusts to try and gain as many responses as we can. Overall, so far I've received 95 responses, but one response was from outside of the UK, so I haven't included that within the analysis. The responses that I've received come from 81 individual healthcare trusts. These encompass all 7 clinical commissioning regions within the UK, and I've also received several responses from trusts in Wales and Scotland. Looking at the responses within England, 40 out of the 42 integrated healthcare boards are covered by responses that I received. The only areas that I haven't been able to receive responses from so far are Norfolk and Suffolk. And the graph on the right just shows the breakdown of primary area of practice of the respondents. So the vast majority of people responding to the survey worked in adult care, but a significant sort of a third, 13% worked across adults and paediatrics, and 10% worked in paediatrics alone. First, we wanted to look at whether or not the individual trusts responding had HLH guidelines that they were able to access and use in the event of a case of HLH. So only 20% of trusts that responded had access to an HLH guideline. 7 of these guidelines had been developed locally. The remaining 9 trusts were using guidelines from external sources. And I think in 7 out of the 9 of these, this was the guideline out of UCL that Harris mentioned earlier. We then also wanted to look at a trust level at anakinra prescribing and how MDTs are utilised for anakinra prescribing decisions at present. So just under 30% of people that responded to the study weren't aware of the updated NHS England policy on anakinra. And anakinra had been prescribed since the introduction of this policy in just under a third of trusts in the UK. This graph breaks down how decisions regarding anakinra prescriptions are made at a trust level within the UK. So based on the responses that we had, you can see that just over half of discussions are undertaken at a local level. Just under a quarter of these have an MDT locally that they were accessing. A third were using informal MDTs. But interestingly, 25% of trusts that responded were reliant on a single centre MDT. And in many cases, the UCL MDT is outside of the region in which the trusts are based. This map is my attempt to sort of chart the current state of HLH MDT provision across integrated healthcare boards in the UK. So you can see the areas in dark blue are those that have some formal HLH MDT provision, going down to the light green where there is individual clinician practice at play. I think it's probably worth saying at this stage that I think this graph probably overestimates the current level of service. I think there's an inherent bias in this study that because it was disseminated via our professional networks, I think it was probably more likely that clinicians that already had an interest in HLH responded to the survey. And then also within several regions, I got responses from multiple trusts. So if we take sort of Sussex down on the south coast as an example, I received 3 responses from separate trusts within that region. 2 of those trusts didn't have access to an MDT, but 1 did have an ad hoc MDT. Therefore, I've essentially rounded up for the purposes of the map the level of service provided to the highest level disclosed within a region. But I think this likely overestimates the provision that's available at a local trust level. Nevertheless, formal MDT provision was available in 31% of the integrated care boards studied. However, only 3 of these integrated care boards disclosed having an HLH specific MDT. One of these was a paediatric MDT and the other 2 were adults. In the remaining regions, HLH cases are discussed in existing either haematology or rheumatology MDTs. A further 37% of regions said that they would convene an ad hoc MDT to discuss HLH cases as and when they occurred. But I think more strikingly, just under a third of regions that I surveyed said that they didn't have any access to HLH MDTs, and instead they relied either on informal discussions with colleagues or in some cases on their individual practice to make treatment decisions regarding HLH. This graph shows the current specialties that are represented within HLH MDTs across the UK. I think it's broadly as you'd expect when many of the existing MDTs that are used are haematology and rheumatology. And then, as we've discussed already, the fact that infectious diseases are frequent precipitants of HLH. Next, we wanted to assess if and how HLH MDT services or HLH work more broadly is funded within the UK. So regarding the HLH MDTs, only 1 MDT said that they had a paid administrator, and this MDT was actually a haematology MDT that was used to discuss HLH cases. So as far as we could identify at present, there's no paid administrative support for HLH MDTs within the UK. Regarding the work of clinicians, at present, 10% of those responding to the survey said that they had HLH work included within their existing job plan. However, a further 33% of respondents said that they would like to have HLH work included within their job plan if this was available. Next, we moved on to trying to assess the potential demand that exists for development of either regional or national HLH MDTs. So a very significant proportion of people said they would value having a regional or national MDT at which to discuss cases, so just under 70%. And 20% of respondents to the survey said they'd be willing to lead an MDT, and just over half said they would be willing to participate in an MDT. Interestingly, a slightly higher percentage said they wouldn't participate or wouldn't wish to participate in an MDT than said that they would value one. So there's a bit of a discrepancy within those figures, which I think I'll touch on in a few minutes when we talk about potential barriers to MDT participation. I then asked a few questions to try and ascertain how a potential regional or national MDT might work. I think given the potential large geographical areas that these MDTs might cover, the general consensus was that these would be best suited to be online meetings that were scheduled regularly, either fortnightly or monthly. And there was strong support that there should be a clear referral pro forma and then either pro forma or email outcome of the decision that had been made. Several people mentioned, particularly those in district general hospitals, that they might not have access to some of the other medical specialties, such as infectious diseases or virology at a local level, and therefore having access to multi-specialty involvement in the MDT would be very beneficial for them. More broadly as well, I think there was strong support that HLH MDTs could play a role in development of local guidelines and training and education in updates in the care and treatment of patients with HLH to ensure sort of a standardised practice across the UK. So, as I mentioned a few slides ago, there were some potential barriers identified to the development of HLH MDTs. I think the overwhelming barrier identified by clinicians was time constraints. So I think most people have existing pressures from their existing workload that's increasingly unmanageable, and therefore they felt that they weren't able to take on additional work, particularly if this was unpaid or outside of their existing job plan. There were some logistical concerns raised, such as the fact that at present there isn't the administrative or IT to support HLH MDTs, which would obviously need to be developed. And then finally, I think some people raised concerns about the relative rarity of HLH and the fact that this means that they have limited exposure to the condition. I think some people felt the fact that they didn't have a good level of expertise at present meant they wouldn't have anything to offer MDTs. Other people were concerned that the relative infrequency of cases would mean that it wasn't worth participating in an MDT, even if it was on a monthly basis. Another issue that was raised was obviously the fact that patients with HLH can present very acutely and often be critically unwell, and therefore that there would be a need for people to have urgent or advice at short notice. And therefore, people felt strongly that mechanisms would need to be in place to ensure that if a patient needed an acute decision making before the next MDT was due to convene, that there were robust mechanisms in place to ensure that this would happen. I suppose I see the solution to that being that if local areas have robust guidelines that they can hopefully utilise, then the MDTs can be used for some of the more challenging cases, particularly if there was a national MDT. The regional MDT could perhaps be referred to in the first instance before escalating it up to a national MDT. So in conclusion, at present, there's inconsistent provision of specialist HLH MDT services across the UK. So at present, approximately a third of regions in the UK don't have any access to HLH MDTs, and many of the HLH MDTs that are currently in play aren't HLH specific. Furthermore, there's a heavy reliance at the moment on a single centre MDT, which is the UCL MDT. But if HLH cases continue to rise, this won't be sustainable in the long term. There was strong support identified for further regional or national HLH MDTs. However, at present, most HLH work is undertaken outside of existing job plans. And also at present, there's no paid administrative support for HLH MDTs. Therefore, for HLH MDTs to work in the future going forward, these need to be properly funded. All right. So just to finish, I'd like to thank anyone who did participate in the survey. Hopefully some of you are listening today. And then particularly I'd like to thank Jessica Manson and Dr. Tattersall for entrusting me with this work and for supporting me in completing it. Thank you.
I think we have to thank you, Miriam, to be honest. But anyway, so thank you so much. Lovely talk. And thanks for doing all this work. So you'll be pleased to hear that you've already got a Norfolk contact. So thank you, Joel Cunningham. He's going to email you. And actually, I have a Suffolk contact. So we should fill your gaps. A question for you, Miriam, please, from Alexis Jones, and also to Beth, who's I know looked at the historic Sheffield data. Really asking about when you think in a patient's journey, the patients are referred into MDTs, and whether there's a way of how we get around that whole, ours are twice a month on a Wednesday evening. We often can't wait. So there's that issue, but also, yes. So the question is really, when in a patient's journey do you think they're being referred, and is it early enough?
So
more data, isn't it? So it's more of a question maybe for Thomas and Beth.
I don't think we've got that kind of, and the problem is when you make the decision about somebody having HLH, there's often been I would say clinically, there's often, when you look back, there's an indolent run-in phase where you think we might have been able to pick this up earlier. But I think you've got to do prospective studies. All the data that we're presenting is reflections of real world, isn't it? We need a prospective registry with a biobank, and we could answer these questions. And I think we're just showing that where we're up to. So I think we've got some good practical management strategies in patches across the UK, and people are clearly very interested, but we probably don't have the evidence base or the diagnostic criteria or the understanding of lumping and splitting of HLH. It isn't all one thing. It sits under an umbrella. We probably need to know more, but we're on that path, aren't we? But certainly in Sheffield, we don't have that data of relative presentation and discussion at the MDM compared to that.
And I'd be interested, Miriam, in what you think your survey would have looked like even 2 years ago. I'm guessing really different. And actually, we didn't ask that question, did we, in the Survey Monkey? But if I was to go back, I'd like to know where we've come from. What do you think?
I mean, I think even my experience locally in Sheffield is that sort of pre-COVID, I don't think most of the non-consultant trainees were aware of HLH, and there has been a significant increase in knowledge. But I think in Sheffield as well, our local guideline has only been implemented within the last year or so. But obviously Dr. Tattersall is very, very proactive with her HLH care. So I think if the Sheffield experience is anything to go by, then other trusts a year or two ago also probably had even less provision than they have now.
And my next question for you is to do a similar map, colour-coded by specialty, to see where HLH fits in people's training, because I think that there are some specialties where increasingly we've now got a special interest group, the British Society for Rheumatology, which is great. But, there are some specialties where I think the training opportunities are being kind of grasped and the profiles being raised, but not perhaps not in every relevant specialty. I don't know what you think about that. I know you're now a rheumatology trainee, but not long off being an IMT.
Again, yeah, I'd say I'm inclined to firmly agree with that. I think when we see the IMT3 trainees come to rheumatology in Sheffield, I think most of them haven't really heard of HLH before they arrive. And just this morning, I took a phone call from an IMT trainee in Chesterfield who had never heard of HLH before and had questions about it. So I think at a more junior level, who are obviously the bread and butter of people seeing these sick patients out of hours on call, I think I'm not sure that HLH is getting well integrated into core medical training at present.
Your next mission, Miriam, should you choose to accept it. Thank you very much. I'll hand back to Rachel. Thank you.
Thank you. So we're running nicely on time, and I would like to invite Sam Clark to the virtual stage. Dr. Sam Clark's a consultant in ICU and anaesthetics at University College London Hospitals, but he's got a clinical and an academic interest in the sort of cardiac implications of inflammation, both in cancer and HLH. He's an invaluable member of our MDT, and we thought it would be very timely to ask him to bring together for us a bit of a summary of where we're up to with the sort of cardiac implications of HLH. And I'm hoping, Sam, you'll be able to share your slides and enlighten us over the next 25 minutes and give us 5 minutes for questions, of which I'm sure there'll be plenty. Thank you.
Yeah, and thank you for that lovely introduction. That's very kind. I am on call for ICU at the moment, and I had a horrible moment at about 3:15 where I wondered whether I was supposed to be presenting right now and ran out of the unit. Luckily I wasn't, and I did remember the time correctly. Listen, I'm just going to try and make sure I can say the slides, and I will try and do as Rachel suggests. And so you should now randomly see that pink and ridiculous screen while I just fire up my presentation.
Yeah,
perfect. Please, I don't, because I have been busy today. That started in the wrong places. It always has. Pretty pictures. Right. Okay. Right. Okay. Let's start there. So I'm going to talk my way as quickly as I can in 25 minutes, because those who know me well know that 25 minutes is enough for me to say hello. But luckily or unluckily for us, it's a subject that we are still learning an awful lot about. And so, we'll take it from there. I don't really have any conflicts of interests other than I'm on the HLH UCL committee and it's things like that, but I don't have anything from another bit. So my journey with HLH started about 3 years ago, maybe a little bit longer. I'm losing track of time, when I had this request as I came out of theatre. Can you do an echo? Because that's what I do. I'm in my background, that's where my interest comes from in ICU. For a query tamponade, I know it's late because it's about 9 o'clock in the evening. And my friend and colleague asked me to do that. And I'm not going to do a lot of details in the case, except to say it was a 24-year-old lady who had come in for a kind of reasons you present with HLH. And to cut a long story short so that I can crack on with most of the talk, she had adult Still's disease, which was the indication for this. But what I met was a young lady talking to me and who looked very well from the end of the bed in the ICU, who was flirting with a bit of renal failure, but nothing for an ICU consultant to get too surprised about, whose heart looked, X-ray looked a bit like that, who needed a bit of Optiflow. And I put the echo probe on it, and this is roughly what it looked like. This is her image actually from the next day. I don't have the images from the original day, but she had severe biventricular impairment, for those who don't look at a million echoes every second, and her stroke volume was 12 mils, and she was tachycardic. And that's one of those things where you sit there, go, A, how is this girl having a chat with me? And that's a testimony to the young. And B, it's one of those conditions where you can look fine, you can look fine, you can look dead and be dead. So it's something that is really quite concerning, but, you know, and I'll come back to this, clinical kind of presentation may not tell you very much, and people can just die. And so we stuck her on adrenaline infusion. We stuck her on something called GIC, which was a very UCL thing to do at the time and is not worth the talk in here. And she got a advanced referral to VA ECMO the next morning and went there. She got that VA ECMO. It was a fairly long and protracted and hairy course. And it is almost a subject. In fact, it is a subject of a talk that that has been done as a whole, but just to get the flavor going. But what I came away with was going, what is doing this to people, and in a way that you can understand that, and where can we go from that? And it kind of built, and gradually as the cases started coming through UCLH more and more and more, started to become increasingly involved in trying to understand how inflammation is related to stuff. And I got to know Jess and got involved. So that's, but what do we know about cardiac manifestations of HLH? Well, it's essentially this, it's a big desert, maybe there's a little bit of trio in it. And that's, so what we know is limited to anecdote, the story I just told, case reports, you know, there are some in the literature, but they are usually describing a certain state of affairs, you know, where it's raised an eyebrow, just like that case I've just done, something has gone, hang on a minute, we need to look at that. Expert opinion, which is forming definitely through things like these regional and national sort of MDTs that we're talking about, and transposing stuff from different conditions. I've kind of put a little bit of about sepsis in here, but it is also worth mentioning, while I remember, that we should also consider CAR-T and CRS is something we can learn something from related to this. And there's PIMS-TS, which I have, I'm sorry, Rachel, I've chosen not to do it in order to try and get through, but I think it is also interesting. And having a look at those four conditions and understanding where each lies and what the similarities are and what the differences are for the cardiac thing will be really important. It's also worth saying, actually, any newish diagnosis where we're trying to get to the bottom of it, this is actually how medicine works, and it's a really good place to be. And I think it tells us what we have to do next. And I heard talk about, you know, having a prospective database, all this stuff, and I would utterly sanction that too from all sorts of areas, but including the area that I'm interested in. So what I'm going to do for the rest of this is talk a bit about our case series that we've got from UCLH, which is growing, and we are putting together to publish to try and expand that next bit to that next stage where there's a case series, and then there'll be something prospective and a bit more organized in there. And that starts where you do the real research from there. But these are some of the questions I asked myself of the database that we have, and what does it tell us? So it stops being just the one anecdote, one after another, and starts trying to put together a bit more of a picture. It's been a really interesting thing to do. We're only part of the way through that, but I think there is enough to talk about. So who gets cardiac dysfunction in HLH? So this is our database. It covers the last 2.5 years at the moment. We're going to shut it down for publication when it covers 3 years worth. But that doesn't mean we'll shut down collecting the data. All the patients in this one are over 18. We do have patients under 18, and I will take advice from people like Rachel on how to use that. There are multiple drivers of HLH, as you can see over there. Hematological disease is the big bit. I think the no causes identified, probably by the time we finish going through our data, we will probably manage to identify some more of them. So what that is at the time where we solidly identifying what the cause was. But I think with hindsight, as you look back at those cases, you'd be able to identify them better now. There's a combination of organ dysfunction that led to the ICU admission in the first place. And all the patients admitted to the ICU had early cardiac imaging, etc., which is quite nice, because it means this is data that's come from echoes and troponins and BMPs and various other bits and pieces that are all related to their early admission echoes. I do throw in a little bit of data about what happens later on. Well, not data, but more, I'll talk about it. But when we fully put this database together, what we do have is patients who did have some data from beforehand on the wards in terms of the detail and things. And I think there is a way of expanding this to help us learn more. So hem-onc patients were more likely to have biventricular failure. We'll come on to that in a bit. So you can be a bit circular in the way you present these things. And the age range in the data was 19 to 76. 11 of the patients were under 40. All of them had some cardiac abnormality on echo. Now, that's a very wide range of things. But when I was looking at doing this in terms of what I called a cardiac abnormality, I said, any LV dilatation, any LV dysfunction, any RV dilatation, any RV dysfunction, significant by that I mean more than moderate or more valve dysfunction, pericardial effusion, and also, which I'll come on to later, an impairment in their strain. But I'll explain a little bit about that more. I'll try not to be too tedious for those of you who don't do it all the time. But what's also worth noting here is we've got 6 of them presented with some kind of cardiac ventricular impairment, so of those under 40. So more than half. 1 was with LV dysfunction alone, but 4 were with biventricular dysfunction. And you can have a look on there and you see that non-survivors are slightly older than survivors. I'm not sure how useful that is in a case series that's this small, and it has also to do with various other conditions, but they're there, and I'll come back to that a little bit later on. Do they have any chronic heart problems? Because I think it's important to accept that, is this new? And this data is people that had documented and known cardiac problems. I'm not saying there weren't people who had undiagnosed problems beforehand, but this was from 3 patients had cardiac problems. 1 was a 51-year-old with a known VSD. And I'll say a little bit more about that later. 1 was a 31-year-old who had had a renal transplant and had an LVH in his whole story, and so had severe concentric LVH, and that did have an impact on what was happening to him. And 1 was a previous CABG patient with known regional wall abnormality, but interestingly was one of the normal echoes when I come onto it in terms of people who had normal LV function. So that probably didn't have too much of an impact on what was happening at the time. Our overall mortality in the ICU, this is not overall mortality for the patients as a whole. Going back and doing the database, of course, when you're dealing with patients with hem-oncology disease changes things as well. And we will also do this data with a 90-day mortality to see what happens with patients who are discharged as well. But in the ICU, it was 33%. As a standard ICU rule of thumb, you could probably add 10% onto that, 5 to 10% onto that for discharge from hospital in any condition as a whole. So, but it was 33%. There were a combination of, that was a combination of organ dysfunction and or primary disease that appeared to have led, so if they've died. It wasn't clearly reviewed, associated with left ventricular ejection fraction, which is the classic way that we all look at an echo. We say echo is normal if the LVF is not normal. So, it may, so some of our issue may be associated with the others. Now, this pie chart on this side here, if we can see my mouse, is not well done down here, especially if you're looking on a small screen. But what this is of those who died on ICU, were the deaths clearly related to people with cardiac dysfunction? And so it's very much my own, I've done this on my own, it's not been validated by other people, but this is just me looking through it saying, did the notes feel at the time that this was related to it? And actually, you know what, I'm afraid, sadly, yes. There was one that was not, and that was a person who had intravascular lymphoma and neurological HLH. He did have significant cardiac issues at points in his admission, but it was a decision to withdraw because he was not responding to the lymphoma treatment, and he never woke up, and it was about wishes and etc. One was equivocal. That's the ones that are equivocal. One was this, and there was another one which was a gentleman also who did not respond to his treatment. The equivocal one I kind of put there because it would require, I think, somebody else looking at it. But overall, if you have cardiac involvement of your HLH that's significant, it seems to have an impact in when you die. Are any clinical observations helpful? And I slightly alluded to this earlier. And anecdotally, yes. Sometimes it can be, you're looking at it, there are patients with lactates, there are patients with low blood pressures. But I think it's worth considering that also anecdotally, I could have easily written this slide the other way around, right? It depends whether your glass is half full or glass is not. But I think what it's worth saying is they're potentially helpful, but what they are not is the definition of all things. And what did what's our case series tell us about this? Well, 94%, i.e. everybody other than one, was tachycardic at some point in the 8 hours preceding the echo. I haven't got the data formally, but looking back at it, nearly everybody was tachycardic prior to coming to the ICU as well. So that was in there. But only 55% were tachycardic at the time of the echo. So it's not a consistent thing that's there. All of them in this series had sinus tachycardia. That's not to say people didn't have AF and other things at other points in time, but mainly it doesn't seem to be an arrhythmia early part of presentation, or relatively early part of presentation. 50% of these had a persistent tachycardia, of that 55, and 22% with tachycardia died, and one of those was prolonged. So overall, it isn't necessarily telling us something about their mortality. What I think I need to do with the data is almost find somebody, I'm going to talk to some people about doing slightly bigger data kind of assessments on this, because I think there may be something in the level of the tachycardia, or whether it resolves and whether it doesn't resolve, that might be useful. But that's a very difficult thing to teach people clinically. Again, end of the last discussion, hearing about how do you teach core medical trainees what to do. It's going to be I think it'll be nuanced for this at the moment to say this is what you should look for outright. Tachycardia is definitely concerning, but it's not, it doesn't tell you who should be in ICU, who shouldn't, by the looks of it, from the ICU patients. BP at the time of the scan it's difficult. I think it's worth saying, if you are hypotensive, that is concerning, but not many are. So only 3 out of 18 were hypertensive. Now, 2 at the time of the scan, which is when the data has been pulled, I want to go back and look, were on NORAD, which is cheating. So you could say 5 out of 18 were hypotensive perfectly legitimately, and I did want to put that on there. One had, of those who were hypertensive, one had the isolated left ventricular failure, one had bivent failure, and one had a normal LV. 2 of those died. So being hypotensive in the small numbers at the moment does seem to be associated with dying. However, I'd point to you that there is a number of people who presented to us who's actually, which I haven't put into this data, partly because some of it's our newer data and some of it's later, where people have arrested on wards, then been resuscitated, then come to us. And mostly in the main, they weren't hypotensive before they happened. What's the incidence, and what do the heart problems that people get in HLH? So, and by that I mean kind of what different types. I said they all have some kind of cardiac dysfunction. And I've got to kind of say it somewhere, I think I'll come to it again at the end, but beware the normal echo report. You'll see why with some of the data, but also when people say normal, sitting on the MDT and this being my thing, I listen to people say their echo is normal, and then what they write down is they've got a pericardial effusion and they've got MR. And, yes, we often walk past that because our cardiology colleagues often say, walk past it, but this is a different disease. This is a heart reacting to an inflammatory process. So sometimes some of the detail may become important to us. So one person had a perfectly normal echo, I think, on admission. I said, no, I think, actually, I'm trying to understand my own data here. I think what I did was I said, there was a few things I put into this in terms of things like 2 of them were strain related. So I took it out at that point. So if you were just looking at a normal echo, as most things are reported at the moment, 2 would have counted as being normal. That's the difference between the previous one. And so 88% have some kind of abnormality related to function. Oh, that's it. The difference was it included a couple of people. I apologize when I put these slides together. I took out the person who had the 2 people who had known LV problems from beforehand, the regional wall bit, which is separate from the previous cabbage, and the person who had the VSD. So I took them out of that because I didn't feel it was potentially related to HLH. 56% had ventricular impairment, which is fairly significant. And how did that break down? What's the nature of that? So one had dilation, four had RV dilation, and I think I can come back to that a little bit later if there's time. 8 had LV failure, so 44%, of which 5 of those had biventricular failure. So all of the ones had at the beginning who had proven RV failure also had LV failure, which is why they ended up as biventricular failure. A couple had diastolic impairment. One of those was on its own. And 28% had at least moderate valve dysfunction. What's also interesting is a fair amount had pulmonary hypertension. And again, I think I don't really come back to that, so I can try and come back to that in time a little bit later as to the relevance of that or not for us. This is first echoes on ICU. If you look at the later echoes, 3 went on to develop additional RV failure. One of the normals went to a borderline function but didn't die. And one of the and there was one that was hyperdynamic that wasn't on there. So that would normally, people, again, you'd be aware of the normal echo. The guy with the hyperdynamic echo was catastrophically terrible because he was the one with the LVH and he had a whole bunch of additional problems as well, but he also had fairly obvious impairment related to HLH. One developed a new pericardial effusion later on. That's the same person as the person who went from normal to borderline. And 3 developed new significant valve dysfunctions as part of it. So there were changes that go on. There's also worth saying that a number of people got a lot better as well. So in terms of the valve function, and this is classified by the new BSC guidelines, and they're simplified compared to what most BSC used to from cardiologists. So what they talk about is they talk about normal, so that's your EF that is sitting between sort of 55, 65, that kind of area, around 60. And that's what we would mostly have at rest. Hyperdynamic, which is sort of 65 plus, definitely over 70. Borderline, which is sitting around 50. Impaired, which is less than 50, but above 35%. And severely impaired. So what it does is it works quite nicely for conditions like sepsis, potentially HLH, is because it takes out all the mild to moderate, all that very nuanced stuff that probably doesn't have an impact on what happens. The colors here may not be obvious from the bottom. The light color here are people who died. The dark color are people who lived. And I would just like to make a really big deal out of this. So what would come out as a normal echo or good had 5 of the people who died out of the 7 on this level of dysfunction. And the other people who died, one of them, they're people with really bad hearts. And I'm going to come on to it. You know, that's just worth sinking in. People with normal hearts and people with really bad hearts die. People with not great hearts in this database survive. Is this similar to sepsis? You could easily ask the question, is this similar to CRS and is this similar to PIMS-TS? But I'm just going to do sepsis because there's more literature in this in ICU. I'm going to do it really quickly. For a start, when you start really looking at the echo data from the papers that are being done, this is a series that showed actually 100% of people had something wrong with the heart, almost similar to this series. When you look in the literature, it does range on the series you look at, and it's somewhere between, and it depends what you call dysfunction is part of the influence, but it is over 50% of people have some dysfunction in the heart. When you look at this, they've classified it in mild, moderate, severe here, which is a difficult thing to truly classify in an ICU. But you know that mostly it's mild. They've got some diastolic dysfunction, which is again an interesting thing to come back to, especially with this, because one of the distinctions I'd make with sepsis is I don't think yet we're seeing diastolic dysfunction so much as systolic dysfunction, and that may be one of the differences. The other thing is they have this, what these would come into the impaired category. So lots of the patients get impaired stuff. And so I'm going to bring back my slides again so we can see that. So we can see that that's similar. Sepsis has a lot of this in it, but they also have this. Now, there are studies that show this, and this is another study that's really very clever slide to try and demonstrate what happens in heart problems, which is in inflammation as a whole. And this is the septic thing. This comes from a paper that does this for sepsis. However, you could easily replicate this if you had enough data in HLH in CRS and in PIMS-TS in some form. The numbers may turn out to be different. But what their suggestion is having a mild impairment may be protective. And while we all learn, who are interested in this area, we all learn that you get vasoplegic and your blood pressure goes down, but your heart pumps really well, and that's considered to be, distributive shock, and you give them NORAD fluids and they get better. Those people actually die when you really look at it. They're really at risk. The people who have a slight drop in their ejection fraction down to this area, but maintain a reasonable contractility. So their stroke volumes are okay, their cardiac output is okay, and they have a bit more of an afterload. That seems to be protective, and those people are much more likely to survive. However, there are also the group down here where they end up in real trouble and they pass away. And this is quite a good way of looking at literature. And I wonder if within those of us who are ICU community, that one of the ways we start looking at what we do with inflammatory hearts is consider this. People up here worry me an awful lot. And I'll just go back to that again. Normal does not mean good. So is there any more sensitive way of doing it? I don't have many more minutes, so I'm just going to highlight this for a second, which is, this is strain. It is a way of looking at the shortening round all the way around the heart. You get graphs that come out that look like this. This is a normal person. These are the different lines that correspond to different parts of the heart. And the short version is, the steepness of this line is like contractility. This is when the valve closes. Anything that's happening after this is no longer useful contraction. And it may be one of the reasons why ejection fraction looks false. It is also the reason why this is more sensitive is it's picking up bits of the heart that stop working while other bits are still trying, which happens in inflammation. And there is lots of strain better way of doing it in all sorts of areas. Cardiologists have been to use this for valve problems and various other bits and pieces as a way of seeing the effects earlier and predicting problems. And those of you who do chemo and cancer will know that it is one of the things that people now do as a normal scan, to test the normal scan, to see whether people are likely to be having impact from certain chemo combinations. This is a paper from ICU and sepsis that demonstrates it is good at sepsis. And the numbers that are important are about, it does depend on the vendor you use. That does make a difference. But in the main, -20 is normal, -15, less than -15 is beginning to be a problem, and does seem to correlate with sepsis in our local data and may be relevant with HLH. And also it's an under -12 starts being a real problem. And this is one of our HLH patients, and you can see it's not red, beautifully red all over. It's got lots of pink. There's lots of bits of the heart that are not working. It doesn't have this nice, beautiful dip here. And this is an ejection fraction that is not great, but it's not terrible. And somebody visually reporting that may report that as normal and may report that as mildly impaired, which wouldn't cause you to be worried. But actually, when you look at this number, it's -14. And there's some very other cool things you can do with that. But that's the kind of thing that is useful and beginning to encourage people to try and get this. We did this for our data. We don't have it on all the people.
Sam, we've got about 1 more minute. I'm
right,
loving
I'm going to stop in a second.
Cool.
So what I was going to say is that this is, we've got it in this data, and there does seem to be, the one thing I'd explain about this graph is 0 is bad, -20 is good. So there is a trend within this that GLS may well tell us who's going to be a survivor and who's not. I'm going to randomly skip on a few slides to my summary take-home messages. Cardiac involvement is common. It can be fatal. It can worsen suddenly. Cardiac involvement is always in danger of worsening if HLH is not well controlled. have a high index of suspicion, do your echoes and your biomarkers, because it will link in well with the other inflammatory markers, and that's the work we'll come and do. Beware of the normal echo report. And what I didn't get a chance to talk about, and probably rightly so, because I've become increasingly tedious, severe bi-event failure does respond well to inodilators or ECMO if it doesn't respond to that. There are issues with ECMO to do with platelets and pancytopenias, etc. But we found if we're doing this and we're managing the HLH, people do get better. And I've got case reports that I can show you of people responding to levosimendan, milrinone, pick your choice. I don't have a vested interest in which one. Thank you very much for listening, everybody.
Great, thank you, Sam. A couple of questions. Sorry to stop you.
No, you're right.
Very sad to do it. There's a question about whether you'd looked at whether any of these patients had received cardiotoxic drugs, particularly some of the hematology.
Yes, I have. I have looked at that, but when I say I was looking at it, this was at 2 a.m, knowing I had an on-call left today, and the better part of Bala said I was going to get stopped anyway.
Okay.
Yes,
but it's obviously an important point of our colleague Andrew Duncan has made.
Yeah, and I think that's the stuff that I wish to come to next. Some of them have, and I do have strains with them. So actually interesting, the people who have that, I've got a bunch of data of people saying strain 21%, they're okay beforehand, because the cardio-onc people are doing this now. So it's going to help me go back and prove, I think, well, it's prove in a 18 case series, right? But at least allude to the fact that they probably don't have that. I also have echoes, some echoes of normal. There is a real flaw in this series. These are patients mostly transferred from other places, so I don't have all the data. I know that.
And Sam, another question in the chat, please, about the use of cardiac MRI. Should we, so number one, when do you do them? Well, it's pretty tricky for us because it involves poor patients going in an ambulance, but that's not a good reason not to do it, if you see what I mean. And then the second question is, how often should you repeat the echo if you have an apparently normal one to start with? So
yeah, both are excellent questions. So the first one, I'm going to answer it as if I actually know something about cardiac MRI. And the reason I'm going to do that is because I had a long chat with Sandeep Bhattacharya yesterday as well to help answer that question, because I kind of knew it was coming. I had one patient in this database who had HLH that was treated earlier in the year and had echo problems and got better with treatment, but there was a kind of indolence series going on. He had a cardiac MRI. All it did was show what the echo showed anyway. However, and then went on. I think there is an argument to do a true research study that does that. But when you really talk to the Mayo Clinic and various other places in the States don't use much cardiac MRI, it is, so you don't need to. Pericardial effusions, trop rise, and strain will tell you exactly the same thing. You've got myocarditis. However, there's nothing wrong with a cardiac MRI if your cardiologists like that too. And I would encourage us proving that cardiac MRI tells us the same thing as an echo, so that when they're sick, we don't have to put them in a cardiac MRI. We already know. And I think that's the thing, is it's about safety and pragmatism more than knowledge about what the right thing to do is.
Okay, great. And then the second question, Sam.
Second question is, if you've got a truly normal echo, if their TROP and their BNP changes or their clinical state changes, I would change it. If they've got a pericardial effusion, I'd probably repeat one in a week anyway. And if it's looking better, then great. But I would do daily biomarkers in that first phase when you think in the way that we measure ferritin, well, maybe not daily, but when the way we measure ferritin, when we think we've got it under control from the ferritin, the HLH, that's when you can stop worrying about this getting worse. And so you don't have to do weekly echo after time for people who are on the ward as well. But if your biomarkers are there, I suspect that will be the answer. The mean BNP in our population was 20,000. I sped past that, of the data that we have. It's incomplete. And what I want to do is see if I can have a look at our ward-based data patients to see if that helps us tell the difference. The BNPs go off, the TROPs go off with the ferritins. That's what that's my anecdotal looking at my own data. I will try and prove that or not.
Thank you. Thank you, Sam. Back to Rachel. Thanks a lot.
Thank you.
Sam, thank you. And if you'd like to stop sharing your screen, that would be really helpful. So
yes, ma'am.
great pleasure to introduce somebody who I've got to know through COVID and who's an incredibly well-respected member of our paediatric rheumatology community. So Grant Schulett's an Associate Professor of Paediatrics at the Division of Rheumatology in Cincinnati. He is somebody who has nailed systemic JIA and macrophage activation syndrome to the research wall and has lots of collaborations in the States. But we got to know each other during COVID and with the advent of the increase in hyperinflammation and the new arrival of what we call in the UK PIMS, which has a lot of relevance to the previous topic, and myocarditis and cardiac devastation of hyperinflammation, and is known in the States as Miss C in kids and Miss A in adults. So we're very grateful to you for overcoming the time difference, Grant, and speaking to us. And I thought it would be really helpful, although we've artificially divided this afternoon into paediatric and adult HLH. In fact, all the sessions have been all age and age agnostic, really. And what I perceive that you do is you use lessons from systemic juvenile idiopathic arthritis, and you have translated those lessons for us into a wider discussion about HLH. And I'm not sure that that's something that the HLH community in the UK, beyond those of us who do paediatric rheumatology, really know about. So I'm so grateful to you for illuminating us, and I'll hand the floor to you, and you get the prize for the best background of the day.
All right, yes. Well, the time change is now working for me, as it is, I can see the sun is setting behind you, Rachel, here. I'm not at the ballpark today. There's actually snow on the ground in Cincinnati, but it is now becoming a bright and sunny day. So let me share and start. All right, are you seeing my slides here?
We are. Well done.
Perfect. All right. Well, thank you very much for the opportunity to talk to this very dynamic and exciting group, and I hope this will be the beginning of many conversations with my UK colleagues. So just a couple of quick disclosures. So what I'm going to talk about first is just review a little bit about macrophage activation syndrome, what it looks like, what we're talking about as rheumatologists when we talk about MAS, and then delve a little bit into the nomenclature problem we get into with our more HLH-focused colleagues, and how this can sort of impair some of our communication. And then consider some of the similarities and important differences in MAS and HLH as they relate to understanding this disease and what drives their pathogenesis. So I'm going to start with a case. This was a child I saw when I was a clinical fellow here in Cincinnati. This was a previously healthy 7-year-old boy who was admitted actually at this time of year with fevers, abdominal pain, and leg pain. He had daily spiking fevers at the time of admission for about 12 days. He was noted to have arthritis involving his larger joints, particularly his knees and his hips, some serositis, and a very classic evanescent rash. His initial labs, you can see some of the highlights there. He had a leukocytosis, small anemia, and sort of a relative thrombocytopenia, which in hindsight probably should have been more of a clue for him. Ferritin initially was somewhat modestly elevated, and then in the course of his initial evaluation, increased to over 16,000. He was seen by my pediatric infectious disease colleagues who sent a bunch of testing, could not identify an identifiable infectious cause. Was seen by hematology. They reviewed his smear. They did not perform a bone marrow examination, but they did not have concern for malignancy, which left us with us as rheumatologists. And we diagnosed him with presumptive systemic JIA and started him on IV pulse steroid treatment. So what is systemic JIA? So systemic JIA is a type of juvenile idiopathic arthritis, and JIA is really a bucket where we lump together children who have chronic arthritis before the age of 16 without another identifiable cause, such as another rheumatic disease, an infection, etc. But really, it's a category that includes multiple pathogenically and genetically distinct diseases, amongst them being the systemic subtype. And so along with arthritis, children with systemic JIA have daily fevers in this classic quotidian pattern, in this very classic evanescent rash, which is described as sort of salmon colored and moves around and is worse with the fever and can have a Kobler's phenomenon, adenopathy, hepatomegaly or splenomegaly, as well as serositis. So after starting steroids, the child initially improved. He became afebrile, his joints felt better, his labs began trending downward, his ferritin, as you can see, dropped, although still quite high. His CRP was trending down. And so based on that, after a few days of the IV pulse dose steroids, we transitioned him to a more typical high-dose steroid, as well as started him on anakinra in anticipation of going home. However, after a couple of days of this treatment, he worsened. He spiked fevers up to over 40 centigrade, became tachycardic and tachypnic. Rash returned, and it had some sort of new features of the rash, including petechiae, as well as worsening belly pain. His ferritin changed direction and began rising again. His platelets began dropping to now in the sort of low end of the normal range. So with that, we went back to these IV pulse dose steroids. We increased his anakinra, as well as added cyclosporin for a concern for evolving macrophage activation syndrome. But despite that, he continued to worsen, continued to have this neutrophilia, anemia, worsening thrombocytopenia. His ferritin pegged the top of our scale. His fibrinogen was dropping. His D-dimer pegged the top of our scale. His transaminases were going up. Clinically, he continued to be febrile and tachypnic, and then developed, as I noted, this petechial rash, which prompted us to transfer him to the ICU. However, upon arrival into the ICU, he developed worsening pericarditis with impending tamponade and underwent an urgent pericardiocentesis. We also gave him a dose of tocilizumab. However, after the procedure, he developed respiratory failure, hypotension with poor perfusion, arrested, and unfortunately died while we were attempting to crash him onto ECMO less than 24 hours after his ICU admission. So I think this case illustrates a couple of things. One is how MAS can emerge in the setting of the hyperinflammatory environment of systemic JIA, how difficult it can be to recognize this early on, and how quickly these children can progress to life-threatening illness. So what is MAS? So MAS, when we use that term, we refer to a clinical picture that includes cytopenias and often pancytopenias, liver dysfunction, coagulopathy, this extreme hyperferritinemia, and clinically leading to multi-system organ failure. Historically, we've said that this can be fatal in sort of 10 to 20% of cases. A more contemporary case series put together as part of the MAS classification criteria project still found mortality of about 8 to 10%. Immunologically, what we see is this excessive activation and proliferation of T cells, as well as these non-neoplastic macrophages or histiocytes. And if you look at them in the tissue, such as the bone marrow, as we see here on the right, we often see this hemophagocytic activity. So again, we as rheumatologists looked at this and called this macrophage activation syndrome. Our hematology colleagues, seeing very similar staining in the setting of patients with perforin deficiency, for example, called this hemophagocytic lymphohistiocytosis. About 15 to 20 years or so ago, colleagues, including Alexei Grom and my mentor in Cincinnati, recognized that there was substantial clinical overlap between these two, and I think now can broadly be considered within this cytokine storm syndrome umbrella. So we see this in association with almost any rheumatic disease, lupus, Kawasaki disease, other connective tissue disorders, some of the monogenic autoinflammatory disorders, but is most commonly seen in children who have the systemic form of JIA. And typically what we say is that children with systemic JIA, somewhere between 10 and 15% of them can have the sort of severe overt episodes of MAS. However, at least a third or so of them can have more mild or sometimes called subclinical or occult MAS, which is some amount of MAS features or clinical or laboratory that are seen without sort of the full-blown clinical picture. And for those who haven't seen it, I encourage you to Google Max the Angry Macrophage, which is a lovely video that's put together by my media department here at Cincinnati Children's, explaining HLH to children. Although I would note that they're really talking about MAS because they don't talk about T-cell killing defects. They talk about these guys, these angry macrophages. So really they're talking about MAS. That's my only note about it. But it's lovely, it's funny, it's very American. So the features that we see in MAS, as I said, are strikingly similar to HLH. And these, as you know, are the HLH clinical criteria. And we see all of these in MAS to some degree. But they're often very difficult to recognize in the setting of rheumatic diseases. Fever, again, a very common presentation of severe rheumatic diseases. Hyperferritinemia, you can see in many children with systemic JIA, even in the absence of MAS, particularly at those lower cutoffs of like 500 or so that we see in the HLH criteria. The cytopenias, the interpretation of cytopenias in MAS is very complicated by emerging in this hyperinflammatory background of systemic JIA and this very dramatic acute phase response. So as I said, this child who I presented at the beginning had a low normal platelet count. However, in a child with a massive fever, this huge acute phase response, normal platelets are abnormal platelets. And not until this child was critically ill did they have a platelet count that would satisfy the HLH criteria. Similarly, with interpreting the fibrinogen level, often these children early will have a normal fibrinogen level, but why don't they have a high fibrinogen level? And then the NK cell activity, this is sometimes not present in systemic JIA. It can sometimes be transient, so also not always very informative. So as I mentioned, both HLH and MAS, I think, are considered by myself and people like Dr. Tattersall as part of this sort of broad cytokine storm syndrome umbrella. And this is now the sort of famous/infamous umbrella put together by my American colleague Scott Canna in the early days of COVID when we were trying to understand, is there a severe late hyperinflammatory phase of COVID that similarly would benefit from immune-directed treatment? Frankly, people who sounded this alarm early, including people from China who wrote case series of tocilizumab, people like my friend Pooja Mehta and ourselves, were proved right by the effectiveness of both steroids as well as medicines like tocilizumab, baricitinib, now anakinra, in the treatment of some patients with severe COVID. However, the cytokine storm syndrome nomenclature and umbrella can be problematic when we sort of oversimplify and we try to say everything under this umbrella is X, and whatever the X is from your particular perspective. It's ARDS from an ICU perspective. It's familial HLH from an oncology HLH perspective. It's MAS from my perspective. Because not all of these are all created equally. They don't all have the extreme hyperferritinemia we see in HLH. Not all of them are IL-6-opathies. Some of them are very self-limited, like CRS, and others are really persistent and require going rapidly to bone marrow transplant, as in familial HLH. So this gets back to this question of the name and how this can often interfere with our ability to effectively communicate with each other across specialties about what we're really talking about. The term of secondary HLH or reactive HLH, which is sort of an older term, the Histiocyte Society would call this secondary HLH, which again, compared to primary familial HLH, they would say, well, this usually occurs later in life, is usually less severe, although the two cases presented by the first speaker in our session this afternoon showed that these primary HLH can present in adulthood and can be fatal. And again, is by definition, there is a trigger, whether that's an infection, a malignancy, an inflammatory rheumatic disease. So MAS as we say it, or secondary as the Histiocyte Society would call this secondary HLH with a rheumatic disease trigger. I often say this is secondary HLH when diagnosed by a rheumatologist. And then what about cytokine release syndrome, which again, officially in the official terminology is secondary HLH triggered by CAR T therapy or similar medications. However, I often think this is secondary HLH when diagnosed by an oncologist. So I put this joke together with my colleague Mike Jordan at Cincinnati a few years ago when we were talking about this topic. And for those who get the reference, I thank you for being of my same generation. But sort of throwing out the topic that MAS and HLH are very distinct diseases, but they share a final common pathway. So now let's discuss that a little bit and think about some of the differences between these two. So familial HLH, we think of really as a disorder of T cell and NK cell cytolytic function. The first genetic lesion identified and the plurality of those that we find in children and adolescents is perforin deficiency. But the primary HLH can present with biallelic or full defects in a number of different critical proteins in this granule trafficking pathway. And really all of these steps here that involve the movement, assembly, proper trafficking, fusion of these perforin and granzyme containing granules with target cells. So what about an MAS? So now for almost 15 years, there has been recognized case reports that some children who have systemic JIA and MAS can have heterozygous or hypomorphic variants in some of these HLH genes. This was shown most rigorously by my colleagues Alexi Gram and Ken Kaufman here at Cincinnati, who performed whole exome sequencing on a large cohort of, or TRIO-S, I should say, on a large cohort of children with systemic JIA with and without a history of MAS. And they found that those with MAS had one or more of these hypomorphic variants over 33% of the time. And this was significantly higher than was seen in patients who had systemic JIA but had never had MAS. And interestingly, they also found a number of other potential variants. Many of them were also related to the granule cytotoxicity or trafficking pathways. We've similarly found, this number of about 35 to 40% has popped up in several other studies that have looked at this in people and patients with various forms of secondary HLH or MAS. We found this in patients with fatal influenza. This has been seen in some case series of early severe hyperinflammatory COVID or other viral infections. And work by Randy Crone and colleagues has shown that these variants are actually functional. They don't prevent cytotoxic killing like you would see in primary HLH, but they slow and prolong it and make it less efficient. And therefore you have these frustrated lymphocytes that are secreting excessive amounts of interferon gamma and as a potential driver of MAS. However, a majority of these patients have no identified genetic lesion. So this is clearly at best some of the story. What we do see that's very similar between MAS and HLH is this profound activation of very, very activated T cells that are producing interferon gamma. So this was beautiful work from Mike Jordan's group here, which showed that in patients with HLH, they see this massive expansion of these CD8 positive, CD38 positive, HLA-DR positive T cells that produce high levels of interferon gamma, as well as other pro-inflammatory cytokines. And they matched them to patients who were critically ill and in the ICU with identified infections and sepsis. And you really don't see this. And so this appears to be a fairly sensitive test for HLH-like physiology. And we're currently working on rolling this out as an orderable test in Cincinnati. A recent paper by my colleagues in Rome from Fabrizio De Benedetti and Giussi Principe's group found very similarly see these same CD38, CD38 high gamma producing cells present in children with systemic JIA and MAS, which are not present in active systemic JIA without MAS features. So we see very similar T cell activation. The other thing that's similar is that high levels of interferon gamma. So it's been known for a while that high levels of interferon gamma really distinguish patients with familial HLH. And then Mike Jordan showed this very nicely with his mouse model of perforin deficiency, which showed that this model was really exceedingly sensitive to interferon gamma blockade, which was some of the foundational work that led to what was, at least in the US, a successful clinical trial of emapalumab, leading to its approval for HLH. So what about MAS? So this was a study performed by Kalia Bracaglia in Rome, as well as folks in Genoa and our team in Cincinnati, where we looked at cytokine levels in children with systemic GIA and MAS. So looking at this table, actually, the left-handed way, actually from right to left, in patients with inactive disease, relatively low levels of these mediators. Active systemic GIA, we see much higher levels of IL-6, but really no change in the levels of interferon gamma or these interferon-induced chemokines. However, when you have MAS, you see pretty similar levels of IL-6, but dramatically higher levels of interferon gamma, but particularly the interferon-induced chemokines, such as CXCL9, which you can see is 20-fold higher than we would see in children who have active systemic GIA but no MAS clinical features. We also had several paired patients from Cincinnati with those who had both a GIA flare and an MAS flare, and you can see that we see much higher levels of these chemokines in MAS, supporting both the utility of CXCL9 as a critical diagnostic marker for MAS, as well as the importance of this in the pathogenesis of MAS. We can further elucidate this with some recent data from our lab. Emily Farvayan, who's a very talented postdoc who came to us from Christoph Kessel's group in Munster. We performed a large single-cell RNA-seq study across the SGIA clinical spectrum, including active and inactive disease, patients who had lung disease, and patients who had overt MAS, with, again, a wide variety of clinical features and treatments being used in them. Identifying cell populations across the immunological spectrum. So the first thing we did was we examined this for looking at the previously defined interferon signature that was seen particularly in lupus patients. And what we saw was when we looked at these sort of several different modules of interferon-induced genes, in control patients and those with inactive disease, we don't see a whole lot of interferon activity. So across the bottom in the x-axis, these are our 27 different cell populations, individual genes up here on the y-axis. Active systemic GIA and lung disease, we see more of this. We see particularly activation of interferon genes in the myeloid compartment, as well as some of the T cells. But when we have patients who have full overt MAS, we see this really impressive spreading of the interferon signature across various cell populations in both myeloid and lymphoid lineages. Looking at this another way, we performed pathway analysis, looking within each of those different clinical groups and in each of the cell populations at the differentially expressed gene sets, and then looked for modules and clusters where we would see multiple different cell populations showing very similar changes in gene expression in particular diseases. And you can see the three largest modules that we saw here are down in the lower right. These are downregulated genes in MAS in lymphoid populations, upregulated genes in lymphoid populations MAS, and upregulated genes in lymphoid populations in lung disease, which shows some overlap in MAS. When we look at those upregulated genes, we see a very extensive transcriptional network. And zooming in at the core of this network, what we see is an interferon activation driven by both STAT1 as well as several IRFs, including IRF1. So very extensive lymphoid interferon-driven transcriptional activation that we see specifically in MAS and to a lesser degree in lung disease. So All right, so we see this very excessive T cell activation. We see lots of interferon. We don't see the sort of frustrated, defective T cells that we have in primary HLH. But what's different than in MAS? And the answer is IL-18. So IL-18 has been shown to be highly elevated in systemic GIA and other related autoinflammatory disorders that have a risk for MAS. So what does IL-18 do? Well, it has many functions, but one of the key ones are to amplify innate immune responses and induce interferon gamma. And so it's thus been proposed that the high levels of IL-18 seen in systemic GIA distinguish both the broader risk for MAS in these children, as well as specific patients who are at risk for MAS. And the role of IL-18 in this process was really very nicely shown in the rare children who have a gain of function mutation in the inflammasome sensor in LRC4, which was shown by Scott Canna to lead to a gain of function mutation with excessive production of interferon gamma, driving activation of T cells, production of interferon gamma, and leading to this hyperinflammatory loop. So this is very nice work from my colleague in Japan, Masaki Shimzo, who looked at a broad cohort of children with systemic GIA and looked at their relative levels of IL-6 and IL-18. And you can see there's a whole range of them, but if you draw a line through the middle of this scatter plot, you can see very striking differences between patients who are in the upper left and patients in the lower right. Patients in the upper left in red had relatively higher levels of IL-6. They were generally older, they generally had more arthritis, and they really never had MAS. The MAS is actually those green circles. MAS episodes are all in that lower right, for patients who have a relatively higher levels of IL-18, and they, as I said, were younger, and were really the only ones who would get MAS. We've seen something similar in our cohort in Cincinnati. This is work by my former fellow, Shima Yazin, who looked at 40 patients across the SGA clinical spectrum. Many of them with a history of MAS. Those higher levels reflect the referral bias of my practice, but most of them did not have active MAS at the time. And what we found was, interestingly, this progressive increases in the levels of IL-18 as you move from patients who had clinically inactive disease and had never had MAS to those who had clinically inactive disease but had history of MAS, those who had active disease and never had MAS, and the highest levels in those who had clinically active disease with a history of MAS. And in fact, those with current MAS had levels that were even higher than that. Shown another way by my colleague Scott Canna. Scott looked at both IL-18 and then CXCL9 as our proxy for interferon activity across a disease spectrum, including patients with systemic GIA, MAS, primary HLH, and infection-associated secondary HLH. So here on the top, what you see is that really all of these disease groups can have high IL-18. It's particularly high in MAS, but it's also high in systemic GIA, as well as those with some forms of HLH. CXCL9, as you can see, as I showed with our data, is usually fairly normal in regular systemic GIA patients, high in MAS and HLH. But what's really striking is what happens when you take the ratio of these. And what you see is this high ratio of IL-18 to CXCL9 across the SGIA MAS clinical spectrum. So what you don't see in familial HLH, and you see much less in infection-associated HLH, although you can see there's quite a bit of variability in that. So this really suggests that high levels of IL-18, and particularly a high IL-18 to CXCL9 ratio, is a very helpful diagnostic marker to help you understand, is this child or patient in the Stills MAS spectrum, or are they more of a familial HLH or non-rheumatic associated secondary HLH spectrum? So coming back to our take-home point, and I hope that I've been able to be somewhat compelling, that MAS and HLH are very distinct diseases, but they share this final common pathway of excessive T-cell activation, hyperproduction of interferon gamma, driving an uncontrollable cytokine storm. With that, I'd like to thank my collaborators, particularly some of the people whose data I showed you, Emily Farvayan and Shimi Yazin, my colleagues here at Cincinnati, and my collaborators across the US, and then my funding sources. And I'd be very happy to take any questions. Thank you.
Grant, that was fantastic. I love this slide. I've taken over from Rachel because, as you know, she's on very important parental duties. So just while we wait and see whether people have questions in the chat, I could ask a question about every slide. It was fascinating. Thank you. A clinically practical question, if I may. At what point do you tell a child and their family, to extrapolate into my adult practice of adult onset Still's disease, that if you haven't had MAS or HLH complicating your Still's by this point or that, it won't happen? So in lupus, we used to say, you've had disease this long, you haven't had renal disease, you'll probably be all right.
Right.
First question.
Right. That's a great question, actually. And probably never, honestly. I think so. The three big causes of MAS flares in systemic JIA, I think, in order from most to least likely, are very, very high disease activity, and particularly at disease onset, which is also what we see in lupus MAS, by the way, infection. So particularly people who are doing well on biologic treatment and get particularly viral or herpes viral infections, EBV, CMV are the big ones, can tip them into MAS. And then some potential medications that can sometimes trigger this. Usually it's early in the disease. And we think that IL-18 can help risk stratify. Of course, within the last year or so, I had a young adult patient of mine who I diagnosed him sort of technically with systemic JIA. He was just under 16, but that's still spectrum, had been on IL-1 therapy, doing great, never had MAS, and then had a very, very severe MAS episode, which was triggered by an EBV infection. So I think they remain at risk. And so I definitely become less concerned if they've not had it at onset, and their IL-18 is relatively low.
So you measure IL-18 clinically now, do you?
Yes, so we can measure in Cincinnati, Rebecca Marsh's lab, the diagnostic immunology lab here in Cincinnati, which in US practice, if you ask someone to send the Cincinnati labs, they'll know what you're talking about. This is where CD25 gets run, NK cell killing, CD107 for degranulation, perforin flow gets all run here. We also run IL-18, CXCL9, and as I said, we're rolling out this a flow-based assay to quantify those CD38 positive, HLA-DR positive CD8 cells that we see in HLH.
That's interesting. So exactly that question's just been asked by one of my adult hematology lymphoma colleagues, asking about the use of flow cytometry clinically. So you've answered that question brilliantly. The second question is about relapse in patients. So it does feel as though some patients can have active adult onset Still's or lupus or systemic JIA, really very difficult to control, and yet they never quite tip into HLH-MAS. Other people, we're just transplanting a young woman, UCLH, where actually she's had it 8 or 9 times with really minimal precipitation, minimal, what's the word I'm looking for? Aggravation of the disease. So there is something, isn't there? It's not, as you said at the start, this ain't one thing, is it?
Correct. And again, likely there's genetic factors, right? So I think it's pretty clear that we see sort of functional hypomorphic loss of function variants in more patients who have MAS than who don't have MAS. But yeah, we also there was a patient I was a little bit involved in who Rebecca transplanted maybe a decade ago, who acted like familial HLH almost. I mean, right, every time you looked at her funny, would go into MAS, HLH, trio, whole genome, didn't find anything. But, again, that's sort of been our practice, right? If these patients, if they're having recurrent life-threatening flares of MAS that you can't prevent with, treating the underlying disease and using things like cyclosporin, then we go to transplant. And then I think some of your colleagues at Great Ormond Street were part of the this case series that Rebecca was part of a few years ago on patients with JIA who they transplanted and had fairly good outcomes, actually.
Yeah, yeah. Brilliant. Well, I think we could carry on chatting well into the evening here, but I'm conscious that it's 5 to 5. I just want to thank you again really so much. We know you've just flown back from one meeting. It's very kind of you to join ours, and thank you. That was a really fantastic keynote speech. Thank you, Grant.
Well, thank you. I'm very happy to be here.
Can I also thank all our other speakers, the trainees, our consultant colleagues, really for pulling together what I hope everybody agrees has been a fantastic afternoon, from the paediatric session morphing into this across all age groups in the last couple of hours. I'd also like to thank Wendy, who's chief in charge of tech, which is always a slightly stressful business in these virtual meetings. And then a really massive, massive thanks to Lynn, who I'm going to hand over to now, who keeps the show on the road, who helps inspire us to do really the best that we can for this group of patients desperately in need. So I'm going to thank you all. I'll shut up now and just hand back to Lynn, who's going to explain to you about, amongst other things, how to get the recording after the meeting. Thank you very much for coming.